Good afternoon. The Senate Finance Committee is now in session, and our first bill this afternoon will be Senate Bill 419. We'll ask Senator Vice Chair Feldman, and he's got a panel, including the Attorney General, yeah. Okay, if you would get seated.
I'll sit at the table. I think members of the committee, I know the Attorney General did bring a PowerPoint, but let me just go over some sort of big picture stuff, and then I think I'll turn it over to the Attorney General and his PowerPoint. But just to kind of lay the foundation, big picture. So in July of 2021, after years of investigation, settlement discussions led by our state's attorney generals from around the United States, including Attorney General Frosch, almost every state, including Maryland, and National Council for Local Subdivisions, including most of Maryland's subdivisions, entered into a preliminary settlement agreement with the nation's three largest distributors of, apologize, my little reading glasses are fogging up here, Madam Chair. The largest distributors of prescription drugs, Cardinal Health, Amerisource, Burgin, McKesson, and the opioid manufacturer, Janssen, a J&J subsidiary, that resolved the states and their subdivisions' claims for illegal conduct in the sale and marketing of opioids. And the settlements are valued at a maximum globally of up to $26 billion over 18 years, of which over $2 billion set aside to pay for private counsel attorneys' fees and pay additional funds to states like Maryland that did not use private counsel for their investigations of the defendants. So Maryland's maximum share out of this big pot of $26 billion is 2.11%, or up to about $492 million. Maryland obtained a higher share than its population would indicate because the crisis has hit Maryland harder than it's hit other states. About 85% of that money must be used for a variety of authorized evidence-based or evidence-informed abatement programs, and I'm sure the Attorney General will describe some of that. So that $26 billion nationally and the $492 million specifically for Maryland, those are the maximum amounts. How much Maryland ultimately receives depends largely on the level of participation of the state's subdivisions. The defendants obviously don't want to settle with states, only have a lot of the local government subdivisions within the state bring their own suits. So to get the full $492 million, Maryland would need to have had 100% participation by the subdivisions meeting the requisite population thresholds. But ultimately, the settlement agreements left it to the states to work it out with their own individual subdivisions for participation, a process which took place between July of 2021 and January of 2022 to enable each of the states to do it. The settlement agreements provided that the individual states and their subdivisions could determine how to allocate the settlement proceeds within the respective states. And so the mechanism, and then finally, let me just say the Attorney General did work with MACO, MML, other officers and counsel for the state subdivisions, and they ultimately entered into a state subdivision agreement in January of 2022, a couple of months ago or last month, to allocate Maryland's share of the settlement proceeds. I'll let the Attorney General describe all that, but the mechanism for all this is we created back in 2019 the Maryland Opioid Restitution Fund. In fact, it was referenced this morning on the floor. And that is where, in that particular fund that was created in 2019, was set up specifically to retain any revenues received by the state related to opioid-related judgments or settlements. And so in terms of the local participation, the Attorney General was able to obtain participation of 58 of our 60 required subdivisions that filed litigation or have populations of more than 10,000. So about 90% of our relevant population are part of this agreement for purposes of determining how much Maryland and its subdivisions receive. The two jurisdictions I believe, are Baltimore City, in the Baltimore City Public Schools, perhaps. I'll let Attorney General clarify that. But because we didn't get 100% participation, we didn't get that maximum amount. But we will receive, I think, an estimated $395 million of the $492 max available under the settlement over the next 18 years. Payments in 2022 will occur in April of July of this year. And so, again, in order for all this to work and ensure that the state and the subdivisions are ready to receive these 2022 payments, the General Assembly needs to enact legislation providing for the appropriation, distribution, and expenditure of the settlement proceeds according to the state subdivision agreement I referenced earlier. So, again, this legislation would apply only to those specific settlement proceeds. Madam Chair, with all that said, I'd ask for a fable on Senate Bill 419, and I'll turn it over to the Attorney General for his PowerPoint to fill in any gaps or details that I may have missed.
Thank you. This is my favorite Attorney General in all the world, guys. He and I came over here from Environmental Matters in the same year. Okay.
Well, it's a pleasure to see you, Madam Chair, and members, it's a pleasure to see you as well. Senator Feldman really covered this very well. I don't have a lot to add. I'll try to give you a little more big picture stuff. But basically, the question this bill asks is how would you like...
Can you pull your mic up?
Yeah.
Yeah.
The question that this bill poses is how would you like to have $400 to $500 million for opioid abatement for the state of Maryland and its subdivisions? And as Senator Feldman said, we were in protracted negotiations with the three largest distributors of opioids and with Johnson & Johnson, a manufacturer of opioids. And the total package provides $400 to $500 million to Maryland. We may not qualify for $500 million because we have one subdivision and a school system that have not decided to join the settlement. And the terms of the agreement are very punishing for states that don't have 100% of their subdivisions participating. The net loss to the state of resulting from the absence of Baltimore City and the public schools is really about $40 million because they would have been paid a substantial chunk of the penalty that we will suffer as a result of not having their participation. And essentially, they concluded we would rather take our chances in court against these entities than participate in the settlement. It's not a crazy decision. I wish they had made a different one, but it's not irrational. I want to thank MACO and MML because we had a long and difficult process to go through with them. There were 60 subdivisions, as Senator Feldman said, who were required by the other side to participate, or that we would suffer substantial penalties if they did not. And ultimately, we achieved near unanimity. It was because of the cooperation we had from MACO and MML. This is a deal that I think virtually everybody thinks is an extremely good one. In sharp contrast, I will tell you that we're in the midst of a challenge to the Purdue bankruptcy, where the Sackler family, which drained about $10.5 billion out of the company in the 10 years before its bankruptcy, has asked to be given bankruptcy immunity by paying in $4.3 billion. Maryland is one of 9 states that objected to letting them go for that amount of money. We're in the middle of negotiating. We actually won that challenge in federal district court. We're negotiating with them, but the point is the value of the Purdue settlement. Purdue was one of the worst, if not the worst, one of the worst actors in this space. And we will, at best, get something like, as things stand now, at best get $6 billion out of that company. These other 4 companies that we're talking about now will contribute the vast majority of monies that any state will recover in pursuit of opioid bad conduct against manufacturers, distributors, and retailers. So this is our biggest pot in all likelihood. And they're big, but their conduct, while bad, was perhaps not as bad as Purdue. At any rate, we think this is a really good deal. The counties and cities agree with us. We need this bill, as Senator Feldman said, to mandate the payments pursuant to the agreement between the state and the subdivisions, and that will go on for 18 years. I'd be delighted to answer any questions if people had them. I can run through the PowerPoint, but I think Senator Feldman covered it very well.
Okay, are there any questions for the Attorney General? Okay, well then we'll look at your product that you brought.
Thank you very much, Madam Chair.
Thank
Members.
you. Okay, all right, let's go with our other two witnesses first. Bill George and Paul Knieber. If you would come up.
Good afternoon, Madam Chair, Mr. Vice Chair, members of the committee. My name is DePaul Knieber, representing the Maryland Association of Counties in strong support of Senate Bill 419. This bill is the product of countless hours of negotiations regarding the most equitable division of funds from the state's recent opioid-related settlements. At the Attorney General's urging, MACO and our counterparts over at the Maryland Municipal League convened a work group to review initial division of funds proposals and develop terms agreeable to all. Now, despite varying county and municipal needs and potential partisan divides, the final agreement that is the subject of this bill has the support of 58 of 60 eligible subdivisions. That includes every county with the exception of Baltimore City. Altogether, this bill ensures an equitable and streamlined approach to getting funds to county and local and other local programs and workers who have been at the front lines of the opioid epidemic. For this reason, MACO urges a favorable report for SB 419. Thank you.
Thank you. Are there any questions? Okay, if not, then we'll go to Bill George.
Good afternoon to the chair, members of the committee. Bill George with the Maryland Municipal League here today in support of Senate Bill 419. Much has been said. I will not repeat some of the details here, but a big thanks to the Attorney General and his staff and Vice Chair Feldman for introducing this bill. As was mentioned, the 60 subdivisions that were required by the National Settlement Agreement to be part of the negotiation included 35 municipalities, all of which signed on to this agreement. That may leave some of you asking, what about the other 122 municipalities in the state? Well, they will have an opportunity, thanks to our close working relationship with the Attorney General and the Maryland Association of Counties. We created a provision for them to be able to access a discretionary and competitive grant process should they be able to develop worthy programs and services to be run through the Maryland Department of Health. So from our perspective, this allows all municipalities, not just those 35 that were identified by the National Settlement Agreement, to access funds to help remediate this opioid crisis now and for the next term or the future of this agreement. So with that, the Maryland Municipal League heartily supports this bill and asks for a favorable report.
Thank you. Are there any questions? Well, I guess everybody participating in this particular hearing have done such a good job that there aren't any questions. Thank you.
Thank you.
All right, that ends the testimony on Senate Bill 419. We're going next to Senate Bill 527. Senator Feldman, Mr. Vice Chair, you have a panel, Jeffrey Wright and Bryson Popham.
Thank you. Put our panel up here. Madam Chair, this is a bill that relates to the topic of adult daycare services. And it's a topic of growing importance as our population continues to age. And for many years, Maryland and other states have offered adult daycare services to eligible Medicaid enrollees. These services are also available on a self-pay basis for non-Medicaid beneficiaries. One reason adult daycare services are eligible for Medicaid reimbursement is because these enrollees might otherwise be, in many cases, in nursing homes, which is much higher, more expensive level of care. And so from a cost standpoint, it's not surprising Medicaid has gone that route. Now, during the pandemic, of course, everything changed in the adult daycare world as it did for the rest of us. Many adult daycare centers, which previously hosted 100 or more folks each day, were forced to close. The providers had to scramble to provide certain services to these enrollees, often when they were still at home because they weren't coming into the brick and mortar facilities. And so during the interim, Delegate Ariana Kelly and I learned of a pilot program that was being conducted in the Massachusetts, where they were working in this pilot with a major health plan to test the efficacy of providing certain adult daycare services remotely. And the idea of trying something similar right here in Maryland made a lot of sense, starting in one or two of our own counties. We took a tour during the interim in a couple of facilities in Montgomery County, actually I think in Senator Kramer's district. And I'll let the witnesses describe some of the services that would be the subject of this pilot, but Montgomery County and Howard County, which have several adult daycare centers, have both stepped up to actually host and staff this 3-year pilot for elderly Medicaid recipients, and jointly staff the task force study that's part of the bill. And that task force will report back to the General Assembly by October 1. And the bill itself, the pilot, sunsets at the end of December 2023. So just essentially how it would work is the Maryland pilot contemplated in the bill would create a position of an integrator. And this person would assist the enrollee in identifying health care and other needs. The pilot would also incorporate the use of electronic communication devices between the integrators and the enrollees. A major objective of the pilot is to provide needed services in addition to, not in lieu of, services that are provided in adult daycare centers today. In this way, we hope we can actually reach a larger population. Right now, there is no integrator set up for a Medicaid enrollee to decide whether additional services are needed, i.e. home health care, for example, and then to seek out providers and enroll that person in the service. So the coordination offered by an integrator through this legislation is viewed as a major benefit. It's also important to note that the pilot program does not contemplate that the entity serving as the integrator would actually be the same as the one providing the services, although they could. Rather, the function of the integrator is to assess the needs together with the enrollee and then provide the necessary information for the enrollee to access that particular service. And then one other, maybe less obvious potential benefit is because of the population that we're dealing with in adult daycare enrollees often live at home, there can also be a significant social isolation problem involved, and this has been demonstrated repeatedly during the pandemic. And one of the phenomenon that's resulted in increased utilization, one thing that's happened is we've seen an uptick in emergency room visits by these same folks, even when there's no actual need for those services. In other words, people who are in the population we're describing have been contacting emergency facilities for reasons other than medical emergencies. So it's our hope and belief that regular contact with this integrator will alleviate this problem to some extent and divert some of the concerns to more appropriate service providers. So basically what Senate Bill 527 does, it establishes both a pilot program and a concurrent study. Montgomery County and Howard are okay with participating and staffing the study. And again, I think this is another example of this committee stepping up like we've done in the last few years, leading the nation with some creative ideas in healthcare. I think this is a creative idea. By coordinating and integrating these services, we believe they will be delivered more efficiently, cost effectively, and moreover, we can avoid the unnecessary utilization of emergency room services. So one thing on the fiscal note, and I'll let the panel talk about it, and I think Department of Health weighed in as well. If I could pull it up, they suggest here that the way that they believe that potentially this pilot would require a waiver from the feds. Specifically, I'm looking at the fiscal note on page 4, and then I see the Department of Health weighed in with testimony as well. It says, MDH anticipates that the pilot program will require federal approval under Section 1915C waiver, and as a result, you can read it yourself on page 4. Now, and I'll let maybe Mr. Popham talk about it. I think that's not correct, because I don't think that they're appreciating that we're talking about a participation here will be voluntary, and if you look at the definition of integrator, there's no mention of reimbursement of that function in the bill. That was intentional. We specifically put it in there. An integrator entity will participate in the pilot at its own expense, and therefore we believe there's no waiver required because it's a voluntary program. There's no reimbursement involved. And so I don't believe, obviously we'll do some follow-up, I don't believe that that is accurate. There would be any waiver required. I think we can proceed under the structure of this bill with the pilot in Montgomery and Howard, report back to the committee, and we'll see what it yields. But they're doing that in Massachusetts. I think it holds out some promise, and I'll leave it with that, Madam Chair. So with all that, I'd ask for a fable on 527, and I'll turn it to the panel to fill in some more details.
Before you leave, Mr. Let me ask, could you do something to make sure that within these two counties that will be in the pilot, there is a broad range in terms of demographics? Because we don't have a real poor county already in it, but I'm sure within every county there are various income levels and levels of stress based on economic conditions. Because I think when we get the results, we'd like to know how it works out for people who are in various economic situations.
Yeah, I think it's a fair point. I welcome some language to throw that into the pilot. Obviously, in Montgomery and Howard, they can structure it themselves in a way that to make sure that the study yields back a good blend of demographic mix. Right. But having said that, there's no downside to putting some language in the actual bill to make sure that happens in those two counties.
Okay, thank you. All right, we'll go now to your witnesses. And first we have Bryson Popham.
Thank you, Madam Chair, members of the committee. Bryson Popham appearing before you today on behalf of Savita Health in support of Senate Bill 527. First, I will thank our sponsor, Senator Feldman, for putting the bill in, as well as Mr. McCurdy, who worked very hard to draft it for us. With me today is Mr. Jeff Wright. Mr. Wright is the State Director for Savita Health. He will describe to you their operations in Maryland and will address specifically, Madam Chair, the question you just asked about demographics. As Senator Feldman said, the world has changed over the last 2 years, and that is true in medical adult daycare, and it's really true for the fragile population that both is eligible for their services and uses their services. Because the centers were closed during the pandemic and people had to stay home, there were specific problems these folks had, as Senator Feldman mentioned. And some of those problems were addressed by Savita and others in this area. One of the things that came out of that, which, as Senator Feldman also said, is being examined in Massachusetts, is the need to coordinate services, different services that this fragile population may need. And I would direct the committee's attention to the definition on the bottom of page 3 of the bill. This illustrates really what the bill is all about. The word integrator is used. When we had our meeting with Senator Feldman, Delegate Kelly, one of them, I forget which one, said, well, we're really talking about defragmenting healthcare, and that is an accurate description as well. We're trying to deliver it more effectively and efficiently, and that is what the function of this pilot program will be. I would like to take a minute and address the letter that the Department of Health has sent. As Senator Feldman said, I respectfully disagree with their statement, and I quote, MDH anticipates that this pilot will need to be approved by the Centers for Medicare and Medicaid CMS through a 1915 waiver. They're ahead of the game. Once the study is done, and once the pilot is done, and we bring the results of that back to you, that's when the time may come for us to seek a waiver or a change in the waiver, not for the pilot. As Senator Feldman pointed out, this is voluntary. The word voluntary appears on line 25, page 3. It's a voluntary association. People are doing this on their own. My client, Savita, and others are welcome to do this. There will be no reimbursement sought for this particular service. Any services that are provided in connection with this will be provided and reimbursed as they are now. But this particular function is not going to be reimbursed by Medicaid or the state of Maryland. The MDH letter goes on to engage in a robust endorsement of the PACE program and likens the PACE program to this pilot program. It says the pilot program shares features with PACE. Respectfully, I think the two are as like as an apple and a banana. The PACE program is essentially a health care program through a managed care organization for very ill individuals. There is one small area of Maryland and Baltimore today where you have the PACE program operating. I know that they are expanding, but the number of individuals likely to participate in PACE is perhaps in the hundreds at the most. This program is already in the thousands, and hopefully it can go more. Mr. Wright will address numbers for you. So while I have all due respect for Secretary Schrader and his staff, I must take exception to a couple of the statements that are made in the letter. And we believe that the pilot program and study as contemplated under Senate Bill 527 is good, it is sound, it does not require any other approval, and we would therefore commend it to the committee's attention and request a favorable report. Thank you, Madam Chair.
Thank you. All right, and we'll go next to Jeff Wright.
Pull the mic up.
Good afternoon, Chair Kelly and committee members. My name is Jeff Wright. I'm the state director with Savita Healthcare. Savita is one of the largest providers of adult day health services in the nation. We currently have 42 centers in 5 states serving over 5,000 individuals. Here in Maryland, we have 7 centers and we serve about 800 individuals on a daily basis. Total in Maryland, there's 110 licensed medical adult daycare centers serving approximately 6,000 people. One of the questions Mr. Popham asked me to address was, what is the potential need or use of this service as we continue to grow? I don't have an exact number, but what I would say is there's a wait list on a community options waiver currently of over 22,000 people looking for these types of services. The pilot program that we're looking at looks to use the integrated care model that Mr. Popham mentioned and defragment care. We want someone who can be a single point of contact for individuals using this service so they can get every potential service they need. What happened with COVID when we had to close down was our individuals no longer had access to any services. We were making phone calls to them, and the industry quickly realized we needed to pivot. We started providing meals at home for them. We provided medications for them. We were all of a sudden a transportation company trying to help them get to their medical appointments because they weren't coming into us. So the benefits of this comprehensive program not only defragment that care, but they're going to work with all those service lines across that continuum of care as well. We're really looking at using 3 different service lines: medical adult daycare in their physical building, home health visits, and virtual health to really wrap around services for these individuals to make sure they have everything they need. Excuse me. I just lost my train of thought, and I apologize. The service model that we are looking to do, again, there is no additional cost. What we are doing is just linking an individual with someone who can help them walk through their care and make sure they're getting all the services they would like to have in the least restrictive environment possible. And we can do all this at a cost savings to the state.
One other question I asked Mr. Wright to address for the committee was during the pandemic, how and under what authority did they, Savita and other home health care providers, not home health care providers, pardon me, adult daycare providers, address the nutritional needs of the fragile population they serve? He had an interesting response about who required it. So Jeff, would you please address that?
So the way we used to provide meals was congregate setting in the centers, and that is what the feds dictated. When COVID hit, the feds allowed us to provide those meals in non-congregate settings. So many of the providers on a daily basis were delivering meals to the home to make sure these people had the nutrition that they needed to have. Some of them, the only meal they got during a day was when they came to medical adult daycare. Some providers provided frozen meals and would do one delivery for a week. Other providers decided to deliver hot meals on a daily basis. But the feds did allow us to do it in non-congregate settings.
Thank you. Senator Benson and Vice Chair Feldman, and then I have one question. Senator
Yes.
Collins. Okay.
Thank you. Thank you, Madam Chair. There are two questions that I would like to ask. Has this pilot program been tried anywhere else to your knowledge? And number two is, I've been trying to find out what the fiscal note is. I know that that it's for 2 counties, but I was curious as to whether or not you all have some idea as to whether, of what the fiscal note would be for each of these counties.
Senator Benson, with respect to the fiscal note, this is largely a voluntary enterprise, not only on the part of my client, but on the part of the county. Perhaps Senator Feldman might have a thought about Montgomery County's participation and what expenses they may incur. I can only say they both were enthusiastic about participating in the study. And your other question, I'm sorry, was about?
That it's already being done in Massachusetts.
Oh, yes, there is a similar, not identical, similar program in Massachusetts that's underway right now. And the chair also asked a question that we haven't answered about demographics. So I'd like to ask Mr. Wright to answer your question, Chair Kelly, if that's okay.
Yeah, the one in Massachusetts. So you all do have fiscal note for that and how much it has operated, but you say it's strictly voluntary?
I don't know the details of the Massachusetts experience. We can get some information about that for you, Senator Benson, if you would like us to.
Yeah, I know that it's something very important. I don't want to, because, you know, I understand what we're trying to do here to make it better for some of these little senior citizens and disabled folks who can't speak for themselves. I understand all of that, but I was just curious about the answer to the fiscal note and where else has it been tried in the country. You're saying Massachusetts?
Massachusetts, as far as I know, is the only other state that has taken up this subject.
But you don't know how much it costs them a year?
I think they are in the same, well, actually, they're not in the same position we are because we haven't started theirs yet. They have been underway for less than a year, and I'll have to ask Savita up there what information would be responsive to your question.
Okay, thank you very much.
Okay, thank
Okay,
you.
the sponsor has a question.
Well, it was actually more of a statement. I should have mentioned, how did I end up with just the 2 counties, maybe some other counties? So originally, it was just going to be my own county because I knew there was interest and I knew they were willing to staff and pay for it primarily. But our crack whip counsel advised me that under the Express Powers Act in our Constitution, I couldn't create this pilot for one county. So I did, have a conversation with Calvin Ball, and they seemed equally. But if there's any other of your counties would like to have a pilot, I'm sure that would be fine. But I had to have a second county, otherwise it would have been an unconstitutional pilot program. So I just want to throw that into the mix, how it kind of evolved.
Okay, Senator Augustine?
Thank you, Madam Chair, and I appreciate that. That was a question that I had, Senator. Thank you very much for that. I know that you mentioned this, but I'm just still trying to get my arms around the PACE program, which of course we're supportive of. It's still in the works, obviously. Prince George's County being one of those places that's doing that. We've been talking with that versus this. And so there seems to be a suggestion that there's going to be a similar requirement with regard to the waiver. I mean, is that based on, that's at least that's the suggestion, obviously, of the department.
Yeah, I don't know, Senator, if a waiver would be required, what the nature of the waiver might be. I do know it's premature now because the services called for under Senate Bill 527, in my opinion, do not require a waiver. They are not medical services, they're not healthcare services, it's not a health benefit plan, and waivers apply to the delivery of those types of services. That's why I directed the committee's attention to the definition of integrator. That is both the noun and the verb that operate for this bill.
That's fascinating. I mean, because the PACE program is very similar to that, though. Wouldn't you agree?
No, sir. My knowledge of the PACE program is that it operates very much like a managed care organization or an HMO. It provides soup to nuts health benefits for a very needy population, and it's a high-cost service that PACE providers undertake here. It's medical services. These are not medical services that are the subject of Senate Bill 527.
It's fascinating. In talking to them, they share with me the wraparound services being really the critical portion of the PACE program. I mean, but we can talk about it another time. Thank you.
So Senator, I would like to add to
Well,
that.
you know what, we're going to have to end it. We can't just keep the colloquy going since you answered his question.
So if I could just, also with the PACE program, it really removes choice for the individual. You give up your PCP, you join their PCP. You need any other services, you use what's available in the PACE program. So one of the big other differences is the choice for that. And Madam Chair, I would just say demographics, we are looking to include everyone who currently comes to medical adult daycare, regardless of payer source, Medicaid, VA funding, private pay, insurance.
Thank you. Thank you very much. I don't see any other questions, so I think that ends the.
Thank you, Madam
We got
Chair.
Dana Kaufman?
She had to go to another ECM.
Okay, well then that does end the testimony on this bill. And we're going now to Senator Lamb.
She's not available.
Oh, he's not, all right, he's not available, all right. Okay, so we're going to Senator Klossmeyer, Senate Bill 656, Children Residential Treatment Centers Education Funding. Senator, take the time you need to explain your bill, and all of your witnesses will have 2 minutes each.
Okay, if they want to come up, I think, do they all know who they are?
You can go ahead and get
Okay.
started.
Senate Bill 656, Children Residential Treatment Centers Education Funding. One of the many roles of government is to ensure that every child has access to free and appropriate education. For children with disabilities, this can mean a placement in a non-public special education program or other individualized care to provide an education. Unfortunately, some Maryland children with behavioral and mental health issues are facing roadblocks that prevent them from getting the care they need. Senate Bill 656 aims to lift these roadblocks and ensure that all children can get the care that they need while still receiving an education. The problem this bill addresses is about when a child gets re-referred to a residential treatment center for mental health care. Currently, educational costs for these youths are paid with state funds in two situations. If the child is approved for placement in a non-public special education program, educational costs are covered by the state and local funds. However, if the child has been receiving an education in a public school, then the parents must undergo what is called a voluntary placement agreement in order for educational costs to be covered. A voluntary placement agreement is where parents give up physical custody of their child to place them in the child welfare system. While navigating this process, youth waiting at an RTC beds are stuck in hospitals, creating a backlog and holding up needed beds. Senate Bill 656 will create a new pathway for families to obtain high-intensity behavioral health services for their youth without going through this burdensome process. The bill will allow local behavioral health authorities to approve funding for a child's educational cost while admitted to a residential treatment center if those costs are not already funded. In short, the bill streamlines, which is so important for children with disabilities and their parents, the process for families, reduces inefficiencies, and increases equity. I am joined by a panel of several advocates who can go into more detail, and I would like to thank the committee for their consideration of Senate Bill 656, and I am requesting a favorable report.
Okay, thank
So,
you.
thank you very
All right.
much.
We'll call on you, the way you've signed up, and you each will have 2 minutes. Okay, we're going next to Regan Vaughn.
Good afternoon, Madam Chair and members of the committee. My name's Regan Vaughn. I'm the Director of Advocacy for Catholic Charities of Baltimore, and here today in strong support of SB 656. I'd like for you to indulge me for a minute and imagine you're married, you have 3 children, you're upper middle class, and one of your children has severe behavioral health needs. You've tried therapy, you've tried in-home services, you've talked to the schools, you've tried medication, but your child has still had 2 hospitalizations. Your house is in crisis. Your marriage has tension, your other 2 kids are suffering, and you've talked to the clinical team, and the medical recommendation is that your child enter a residential treatment center. So you say, okay, what do I need to do? What do I need to do for my child? And you're told to call the Department of Social Services. And you say, DSS? And the clinical team says, well, yes, your health insurance is going to cover the medical costs of the residential treatment stay, but you need to cover the educational costs for it as well. And so you have to go through DSS to get those educational costs funded. So you pick up the phone and you call your local DSS office, and they tell you right off the bat, you are going to have to voluntarily place your child in the child welfare system. You're going to be required to pay child support. You are still responsible for the basic needs of your child. You're going to have to undergo a home study, and you're going to have to go before the local care team and prove your child does actually need residential treatment. So you say, okay, I've tried everything, I'm going to do this. I will tell you a lot of families drop out at this point. You go in, you allow them to come into your home to examine it, you go before the care team, you bring the psychiatrist notes, you talk to them about it, and about 50% of VPAs are approved of those who apply. And you get it approved. And then you're told if your child needs more than 180 days in the RTC, you're going to have to go to court. Your child will get an attorney, but because of your income, you probably won't. And this is just to pay for the educational costs of your child. Can you imagine if we did this to parents whose kids had cancer or other somatic diseases? But because it's a behavioral health condition, we are making parents jump through hoops to prove their children need medical care. And it's not okay. There needs to be a better way. We need to take child welfare out of this process and let the local behavioral health authorities make the determination if a child needs treatment, and if they need their educational costs covered, the state should be covering those without parents having to put their children in the child welfare system. SB 656 proposes to do just that, and I would urge a favorable report for this bill. Thank you.
Thank you. Very riveting testimony. All right, we're going next to Celia Serkin.
Yes, good afternoon. I am Celia Serkin, Executive Director of the Montgomery County Federation of Families for Children's Mental Health, a family support organization that helps Montgomery County families who have children with youth or young adults with behavioral health challenges. We have a strong and long history of working with families whose children, youth, needed residential level of care for clinical reasons. We are here in strong support of SB 656, and we believe strongly that this will eliminate the inequitable way that families who have youth with non-public placement on their IEP or not in special ed have been treated when trying to get their children in RTC level of care. When voluntary placement was first established, it was established to help families, particularly with private insurance, not have to relinquish custody in order to get mental health services. We have parity legislation now, and we have many, many efforts going on right now to strengthen parity for behavioral health services. So we're in a different place than we were when VPA was first established. There is no justification to have two separate pathways for young people who need behavioral health services at an RTC level of care. This inequity needs to be eliminated, and we believe the bill will do that. And state funds, general funds, which are already used to pay the education costs of a youth in a voluntary placement, can go through MDH instead of DHS. So you're doing just a cost shifting to another department. In addition to inequitable treatment, we are very concerned that families have to pay child support if they're approved for VPA. Family expenses, rent, mortgage, car payments, utility bills do not decrease when a child is in an RTC. In fact, many families are still experiencing financial and food insecurities during an inflationary period when prices for food, gas, and many other items are increasing. Families already went through a pandemic-induced recession during which many lost jobs and could not pay their rent. And we work with many families now who still are seeking help to pay their rent. Many pandemic-related relief programs have ended, and that families cannot access these programs. And throughout the years, we have witnessed families who did not get VPA for a variety of reasons still go through a SINA and relinquish custody. And this is the antithesis of what we wanted for the VPA legislation. We do not want families to relinquish custody. We strongly urge you to support this bill, and we appreciate your ongoing commitment to help Maryland youth with behavioral health needs and their families. Thank you.
Thank you. Are there any questions? Okay, then we'll go next to Ann Geddes.
Hello, good afternoon. Thank you, Madam Chair and committee members. My name is Ann Geddes. I'm the Director of Public Policy with the Maryland Coalition of Families. MCF provides family peer support to families who care for a child or other loved one with behavioral health needs, and I'm here in support of Senate Bill 656. As has been said, Senate Bill 656 would remove that requirement that parents and caregivers with a child on Medicaid who needs RTC level of psychiatric care but does not have a non-public school placement on an individualized education plan or IEP do a voluntary placement agreement and have their child enter the child welfare system. Under the current system, the dollars to pay for the educational placement in an RTC come from state general funds and run through the Department of Human Services. The bill provides that these dollars should rightly run through the Department of Health. It is a matter of accessing psychiatric treatment and not a matter of child abuse and neglect. Two mothers, both of whom are single moms, have submitted written testimony today. They both had to go through the VPA process in order to access the psychiatric treatment that their child needed in an RTC simply because the child did not have a non-public school placement. I urge you to read their testimonies. In addition, I interviewed one mother who said that she never actually had the VPA approved, but was told by DSS that instead she should report herself to DSS and relinquish custody of her child to the state. The current process is a nightmare for families. It typically takes many months, and these families are in crisis now. Some of these kids are those who are cycling in and out of emergency departments and hospitals while they are waiting for a VPA to be approved. Some of those are stuck in inpatient hospitals for months waiting for approval so they can enter an RTC. These kids are not safe to be in the home. Families must enter the child welfare system, have a home study done, agree to pay child support, and we have heard of amounts of $1,500 to $2,000 a month for a middle-class family, and go to court if their child needs to stay in an RTC longer than 180 days. DSS workers are tasked with making a psychiatric determination. This decision rightly rests with the local behavioral health authorities, who are now making that determination for a child who does have a non-public school placement. We know that the LBHAs and CSAs will need additional help to take on this new responsibility, and we ask that a position be added to BHA staff to support the work and urge a favorable report on Senate Bill 656. Thank you.
Thank you. Are there any questions? Okay, and we're going next to Margot Quinlan, Maryland Health Association, Mental Health Association of Maryland.
Great. Thank you, Chair, Vice Chair, members of the committee. My name is Margot Quinlan with the Mental Health Association of Maryland. The Mental Health Association and our Children's Behavioral Health Coalition are in strong support of this legislation. We really see this as increasing access to treatment for youth and reducing barriers to care, as you've already heard. Currently, families are facing really undue barriers to entering their children into medically necessary care, and this has the adverse effect of long hospital overstays, backlogs of youth and families waiting on treatment beds, and ultimately creates a dangerous situation for youth and their families in a time of crisis. We see this as a simple administrative fix that will have significant positive impacts on children and their families. This is about making government more efficient and ultimately making behavioral health treatment more accessible for our youth. The senator, we appreciate, has put in amendments. We've had a lot of conversations with the local behavioral health authorities and other advocates to make this as strong of a bill as possible, and so we would urge a favorable report on this bill with the amendments that were put in by the sponsor. Thank you.
Thank you. Are there any questions? Okay, if not, you guys have done a good job. Did we get to everybody? Did you testify? Okay. All right. Thank you very much, and that ends the testimony then on this bill. Okay, we're going next to Senate Bill 460, Senator Augustine, Consumer Health Access Program for Mental Health and Addiction Care Establishment. Senator, take the time you need to explain your bill, and I'm going to call up the following people, your panel: Ellen Weber, Courtney Burgin, and Ann Geddes. And all of the other testifiers will have 2 minutes each.
Thank you, Madam Chair, and members of the committee. Senator Malcolm Augustine here, asking for a favorable report on Senate Bill 460, Consumer Health Access Program for Mental Health and Addiction Care Establishment. The Senate Bill 460 establishes a 3-year pilot consumer health access program, an Ombud program, that will help providers, consumers, including those who are uninsured, and their families navigate insurance-related barriers to behavioral health care across all types of insurance coverage. They will do this through direct assistance and representation, community outreach and education, data collection and analysis, and by identifying problems. Then they will work together collaboratively with state agencies and the Maryland General Assembly to solve them. The University of Maryland Baltimore Center for Addiction Research Education Services has been identified and will serve as an incubator in year 1, responsible for selecting a centralized hub organization for the Ombud program and identifying a community-based organization partner, spoke, in each of Maryland's 8 connector entity regions. Colleagues, this will be an independent entity that is solely focused on helping Marylanders navigate, understand, and utilize fairly our behavioral health system. Now, Chair Kelly, Vice Chair Feldman, 1 in 5 Marylanders live in an area with a severe shortage of mental health care providers, as you all know, as we hear in this committee all the time. Of those with a diagnosed mental illness, 1 in 4 have an unmet treatment need. Maryland currently has one of the highest rates of death by overdose in the country. For over a decade, federal parity laws have prohibited most private and public insurance plans from placing stricter limitations on mental health and substance use disorder coverage than they do on specialty medical or surgical services. But as you all know, from the times that we have been in here, we've had some trouble with compliance with the Parity Act in the state of Maryland. Now, despite the disparities in these protections, Marylanders, and in keeping with them, Marylanders are 9 times more likely to go out of network for inpatient behavioral health care and 10 times more likely to go out of network for behavioral health office visits when compared to specialty medical care. These disparities are twice the national average and among the worst in the nation. Even treatment limitations are explained when claims are denied. There may be no way of knowing how those limitations compare to those placed on specialty medical surgical services. It's nearly impossible for healthcare providers and consumers to catch on their own. It's very complicated. It's just very difficult. Now, compounding the problem is a lack of a centralized point of contact for Marylanders needing behavioral health care, regardless of the insurance, as I mentioned. So we ask the question of why an Ombud program is needed. Well, Marylanders are not aware of state and federal parity laws, let alone the type of insurance or plan they have in order to identify the right resources for them. 2018, there was a survey of consumers that they were more hesitant to challenge a denial of behavioral health care than they would be to challenge a denial of medical care. And current resources are fragmented and often limited in scope. Now, this program will help coordinate, link those resources so fewer Marylanders fall through the cracks. The program will have the capacity to offer help in multiple languages, will be staffed by those with lived experiences with mental illness and substance use disorders. Now, the program will have the capacity to identify systemic issues with access and coverage and recommended ways to address them. There are similar programs in Connecticut and Vermont, but I want to highlight the one in New York, because the one in New York actually is focused on behavioral health. All 3 of them do good work, but the one in New York is focused on behavioral health. They have proven track records in reducing costs for consumers and connecting them to care that they need. Now, colleagues, just to sort of like lay where this is, when you're out there and you got a person who is maybe a loved one, they're struggling, and you know there maybe their anxiety or some issues or concerns that are out there. I mean, where do you go? Where do you go? So many times we just really don't know where to go. We may go to our primary care, and our primary care may or may not know where to send you, quite honestly. They may say, well, we'll give you a prescription to go do something, but we don't really know any of the providers. We don't know sort of what's out there or where you can go. You may find yourself then when you go and you look in you go to your insurance, that your insurance may say that the closest provider is in the next state. I speak from experience on this. What do you do? What do you do in a situation like that? You may then go and start asking around to other providers, because now you're just getting desperate. And so you may ask providers, you may just go to a phone book and start just randomly making calls, trying to figure out where to go in order to get service. And when you call folks and they ask you, well, do you have insurance or do you not? Or we don't take this, we don't take that. What do? You really don't know what to do. What a lot of people do is they live with it. They end up in that group that we talked about that are not getting the help that they need or the needs of their loved ones. I shared this story, members of the committee, with the folks at the Maryland Insurance Administration a couple years ago. And they said, well, why didn't you reach out to us? We have a program, and I said, I didn't know about it. How was I supposed to know about that? Well, it was supposed to have been shared with you by the all these things that we're supposed to be and you're supposed to get that just wasn't happening as a consumer. And I said, you know what? We just lived with it. We simply lived with it. And so that's what this bill is really about. Now, there have been questions, because there's no doubt about it, that there is work that is done in the state of Maryland around this area. There's just no question about it. The Office of the Attorney General has a subsection. I'm not exactly sure if I'm saying it the right way, but they've got a subsection. It's I gotta find it for you all, because this is also part of what happens to people, okay? So the Office of the Attorney General, you go to the main website. That's the reason why I brought my laptop over here. On the front page, we got protecting seniors, consumer protection, environment, public safety, unemployment, identity theft, lots of things over here, none of which kind of points me in the direction of where I'm supposed to go with regard to behavioral health services. But if I go to consumer protection, only because I know, and I've done this homework, I can get in there and I can see where they're talking about unemployment, fraud, residential evictions, COVID-19, and other things, COVID-19 and Spanish and other things. And I got to keep looking, but then I do see on the left, after some other things, Health, Education, and Advocacy Unit, which is a resource. Now, the Health, Education, and Advocacy Unit is a resource, and it does good work for the people of Maryland. But the Attorney General, as we know and hear, he's done wonderful things. They've got too much on their plate. Let's just be honest. They just do. We say that in here all the time. They've got too much on their plate. I want to support what they're doing here, but it's simply not enough for the needs of the people of the state of Maryland. And this Health, Education, and Advocacy Unit is about health. I'm talking about the crisis that we have in behavioral health right now, and that we desperately need a centralized location in order for us to be able to meet the needs of the people. Now, the Maryland Insurance Administration, it's a similar situation, where they too are a resource, and they do help Marylanders. I'm not trying to say that they don't, they do, when they are trying to deal with denials of claims. Now, again, there are all those places along the way, which I shared with you, where people just fall out of the process and suffer, which is what's happening. Marylanders are suffering. But the thing is, folks, and I've got answers, they've asked some questions for us, and I've got some answers to that, but I'm not going to go into that. My folks on the panel are going to do that. I'm happy to answer questions around what they have with regard to MIA and HEAU. All I will say is that we can fix some of the sort of the little things that are around the edges. The big takeaway is that they got a whole lot of other stuff to work on, including MIA. You all know that. They're in here quite a bit with us. We know the scope of their work. This is about a focused, independent entity that's solely helping Marylanders navigate, understand, and utilize fairly our behavioral health system. And colleagues, I'm asking for a favorable report on Senate Bill 460. Thank you.
Thank you. Okay, I don't see any questions, so we'll, Senator Feldman.
Yeah, Senator Augustine, just real quick, the $1 million fiscal note, because of that, it's going to have to kind of get signed off. If you had any, just put it out there, any conversation with anybody on the B&T, Chair Gazzoni, or?
I have not, but obviously I'm
Okay.
more than willing to do that.
Okay, I just want to put that out there.
Appreciate
'cause
that.
We would have to do that.
Yes, sir.
Okay, now each of you panelists will have 2 minutes each. We'll start with Ellen Weber.
Thank you, Madam Chair. My name is Ellen Weber. I'm with the Legal Action Center on behalf of the Maryland Parity Coalition. I want to thank you for the opportunity to testify in support of SB 460, and we really want to thank Senator Augustine for his leadership in supporting the Consumer Health Access Program bill, which will help Marylanders with mental health and substance use disorders enroll in insurance, understand and navigate their benefit coverage, and get legal assistance when a denial of care must be appealed. His very thorough explanation really sets the stage for all of our testimony, and we want to thank him for providing that information. In this time of unprecedented need for behavioral health treatment, the Consumer Health Access Program, or CHAP, would be a one-stop shop, a single point of entry to help consumers get the care that they need, regardless of the type of insurance that they have, and assist their providers who very often serve as their patient's advocate. Many Marylanders never access mental health or substance use disorder treatment because the insurance systems, and we have many systems, are complex, and individuals and families need substantial hands-on help to access those services in a crisis. CHAP would have one centralized non-governmental hub and 8 nonprofit organizations across Maryland so that it has both on-the-ground presence in communities for outreach, education, and assistance, and a virtual helpline and portal. CHAP would be staffed by individuals with lived experience to reduce stigma, and it would have an equity focus to ensure culturally appropriate services and identify inequities based on race, gender identity, and language. CHAP will work with various state agencies and non-governmental organizations that offer assistance on the same types of activities that CHAP would provide to supplement those activities and to make sure that individuals have one stop, not 15, with their problem left unresolved. But none of those state organizations provide assistance as a single entity for all insurance-related problems, regardless of payer, individual plans, qualified health plans, Medicare, Medicaid, or the soup to nuts services from enrollment to understanding insurance coverage and providing a network provider or to filing a complaint. No state agency is...
You're going way over your time.
May I finish up?
Sure.
Thank you. No state agency is authorized to provide direct client representation, and none, and this is very important, are evaluating barriers that clients consistently fall through. So CHAP will provide individual assistance, systemic review, and as Delegate Senator Augustine said, other states have these same services. We urge a favorable report so that Marylanders will have them also. Thank you very much.
Okay. Thank you. We're going next to Courtney Burgin.
Good afternoon, Madam Chair and members of the committee. My name is Courtney Burgin. I'm here in support of Senate Bill 460 to enact a consumer health access program because in my experience, accessing mental health care can be nearly impossible to do alone. I struggled to access appropriate care for almost 2 decades. I couldn't find providers, I couldn't get my insurance to pay for providers, and it nearly cost me my life, quite frankly. And I can tell you that with that $1 million fiscal note, that pales in comparison to the healthcare costs that were racked up just for me alone when I couldn't access appropriate care. And being able to access appropriate care now, it has fundamentally changed my life. But that required me to contact countless organizations in crisis. I had moved states just to have access to appropriately trained providers. And I moved here, I called 50+ in-network providers, couldn't find one that was covered, and it wasn't until I testified right here in 2019 that that care eventually got covered, and then it started all over again. And that process, I was fortunate. I know my dad worked in insurance. I know how to navigate insurance pretty well compared to most people. But I have friends right now who are struggling. I have friends who have died. And I don't want to see any more Marylanders lost because they can't access appropriate care. The difference it made when I was able to connect with advocates who stood by me and walked through that process that I just happened to connect with because I was frantically contacted. I was just Googling, like Senator Augustine said, places to contact, randomly just cold calling places, begging for help because I was desperate to fight for my life at that point, and I knew finally appropriate care was within reach. I just needed to figure out a mechanism to pay for it. It was the final step. And with the help of advocates like Ellen, I was able to get that care. Now I'm in law school. I just completed the fall semester with over a 4.0 GPA, and I'm doing great. And I just want to see other Marylanders have that same opportunity. Thus, I ask you to issue a favorable report on Senate Bill 460, enacting the Consumer Health Access Program.
And congratulations on that 4.0 GPA.
Thank you.
Okay. All right, we're going next to Kim Warman. Oh, wait a minute. No, we need to get to Ann C.
Thank
Yeah,
you, thank you,
Geddes.
thank you,
Okay.
Madam Chair, committee members. My name is Ann Geddes, again with the Maryland Coalition of Families. I'm here in support of Senate Bill 460. The COVID-19 pandemic has had a profound negative effect on the mental health of children and adolescents. All studies that have been done paint a very sad picture. Increased suicide rates in youth aged 10 to 14, increased emergency department usage for psychiatric crises by children and youth, and a high percentage of youth reporting suicidal ideation on the youth risk behavioral surveys. Therefore, not surprisingly, the demand for behavioral health counseling has dramatically increased in the last 6 months, year. Families now report that they are unable to find an in-network provider that is taking new patients. At best, their child is put on a long waiting list. Some of these youth who are waiting for services are cycling in and out of crises utilizing emergency departments. Senate Bill 460 would create a central place where families could call to get help accessing behavioral health services. They would be informed of their rights, for example, their right that they don't have to wait 6 months to get an appointment. They would get help finding providers, and they would get help filing appeals and complaints. It's especially our substance use families that run into a lot of barriers with denials of coverage and need to file an appeal, need to file a complaint. They don't know how to do that. They need help. So therefore, we urge a favorable report on House Bill 460. Thank you.
Thank you. All right. Then we'll go next to Kim Wyman. And let's see, and if Ann Seacott is here, Ann, you could come to the table. Natalie Bussath and Mariah Cyphers. You have 2 minutes each. You may go in order.
Thank you. I'm Kim Wyerman. I'm here for Maryland Addictions Directors Council, or MATSI. We're an association of residential and outpatient treatment providers for substance use disorder and dual recovery. We're here today in strong support of the Consumer Health Access Program. MATSI providers are at the front lines of the opiate epidemic in the state of Maryland, and we see firsthand the need for one source for consumers, for insurance benefits, as well as for outreach workers to be able to get people into treatment. We know that time is of the essence when we have someone who is willing to go to treatment, and that immediate action is needed. In the fentanyl epidemic, we literally are talking about life-saving treatment when someone is ready, and any administrative jostling over in-network benefits or insurance coverage can be the factor that keeps that person from life-saving treatment. There are a couple of just a few facts that really demonstrate the tremendous need for this program. SAMHSA's key indicators for mental health and substance use in 2020 reported that there are approximately 41 million people in the United States with a substance use treatment disorder, and of those, only a little over 2.5 million receive treatment. We have lots of work to do. There are 37.5 million people who don't even believe they need treatment. Of the people who believed they needed treatment, SAMHSA reports that 20% who believed they needed treatment but didn't receive it cited the main reason as their health care coverage or the need to pay for that coverage. In Maryland, we had almost 2,900 people die of overdose, just under 2,900 people die of overdoses, the 7th highest in the nation. In Baltimore City, where the treatment facility that I run provides treatment, since calendar year 2018, for every year we have had 1,000 people die from overdoses, mainly fentanyl overdoses. When I look at those numbers, I don't say, why do we need this program? I say, why haven't we put this program in place? Thank you.
Thank you. All right. We're going next to Ann Seacott.
Thank you, Madam Chair, members of the committee. I'm Ann Seacott, representing the Maryland chapter of the National Council on Alcoholism and Drug Dependence in favor of Senate Bill 460. We thank the sponsor for bringing this forward. I'm excited to be talking to you here today about a new initiative. We have been talking with you for many years about issues related to substance use treatment, mental health treatment. And you all have done a great deal of work related to expanding healthcare eligibility, access, coverage. You really have done a lot. The federal government has done a decent amount as well. And so when we talk about issues related to eligibility for programs, when we talk about parity and the need to make sure that behavioral health services are on an equal footing with access to somatic care, we've come a long way. This kind of program, this Consumer Health Access Program, is the kind of thing that can pull it all together and really help make sure that people are accessing that care, to make sure that the insurance that they have is able to get them in the door in order to get the treatment that they need. One of the reasons NCADD is so excited about this is because the vision is that the services, the navigating, if you will be done by people with lived experience. And NCADD is a very strong supporter of peer services, peer recovery services, and we think that this is something that is going to just really move the needle when it comes to making sure people are getting the access that they need. So we do ask for your favorable support.
Thank you very much, Ann. Okay, we're going next to Natalie Boussat.
Thank you, Chair Kelly, Vice Chair Feldman, and members of the committee. My name is Natalie Busaith, and I'm here testifying in support of Senate Bill 460 because I know that if I didn't have access to psychiatric medication that I take every day and therapy that I go to every week, I wouldn't be functioning, let alone sitting in front of you here today. I say this knowing that it is a professional risk to put that on public record, but I'd like to think that it's no different than the fact that my father takes medication every day to keep his cholesterol down and prevent a heart attack. That's just what ongoing health maintenance looks like. Now let's say you've heard kind of a nuts and bolts explanation of the bill, but I want to provide a consumer perspective from someone who doesn't really know anything about insurance. So let's say my insurance denies treatment or access to care, and let's assume that I'm aware of parity laws, I'm familiar enough with state and federal parity laws to know if they apply to my situation, and I'm familiar enough with my insurance company's medical and surgical coverage enough to detect a parity violation. And on top of that, let's assume I have the capacity to advocate for myself while either paying out of pocket for the treatment that I need or going without treatment. Mind you, going without treatment means risking the return of panic attacks, flashbacks, self-harm, and thoughts of suicide. So I'm either taking on that financial burden or I'm paying for it with my health. Now these are a lot of assumptions, but let's assume that I can pay out of pocket long enough to keep my job, stay stable enough to navigate the appeals process. A quick Google search will tell me that there are some resources for me, and it depends on if I have public or private insurance. All I know is what's on my insurance card. I have Anthem, and it's a PPO. But let's assume I know that that's private insurance. The steps outlined for me are to wait for a letter from my insurance company explaining their decision and steps for filing appeal. If I need help with filing appeal, I can call the Maryland Attorney General's office. Now, at that point, I might think, I can get a lawyer, right? I'll call them and find that they can only help me with filing the appeal, but they cannot represent me through the process. Now, if that appeal is denied, then I can file a grievance with the Maryland Insurance Administration, assuming that I have made it that far. Now, you have my written testimony.
Really going well over time.
I understand. You have my written testimony, so I won't take any more of your time. What I really want to emphasize is that this program would not duplicate or replace existing resources. It would simply provide a single point of entry to those existing resources and fill in the gaps so that all Marylanders, regardless of their insurance coverage or their situation or their capacity, can get the care they need. Thank you.
Thank you very much. Senator Augustine.
Thank you, Madam Chair. I just have to stop, and Natalie is a Johns Hopkins intern working in my office this session. She is an amazing woman who has really helped me to put together all of the behavioral health bills that I've worked on. She's obviously a brave woman as well. She's here and just done a wonderful job, and I just want to say thank you to her publicly for all of the work that she's done to make Maryland a little bit safer for people who are dealing with behavioral health issues. Thank you so much, Natalie.
Okay, thank you. All right, now we are going to Mariah Cyphers.
Good afternoon, Madam Chair and members of the committee. Maura Cyphers with Compass Government Relations, here on behalf of the National Alliance on Mental Illness, Maryland. NAMI is the nation's largest grassroots mental health organization. I would really love to just say a strong Me Too and get the heck out of here, but there are a couple really important points I want to emphasize. In 2008, the Mental Health Parity and Addiction Equity Act passed. Then we passed the Affordable Care Act, both major federal landmark pieces of legislation that still left so many people with mental health issues uncovered and unable to access these life-saving services. I'm going to keep it really short and sweet and just say that, NAMI believes there's no health care without mental health care, and NAMI Maryland believes that there is no parity without your continued advocacy and action on behalf of our loved ones and our family members. So please, we urge your most favorable support for this bill. Thank you.
And thank you very much for your testimony. And finally, we're going to hear from Neil Kohanis. You have 2 minutes.
Good afternoon, Chair Kelly and members of the Senate Finance Committee. For the record, Neil Kohanis here on behalf of the League of Life and Health Insurers to testify favorable with amendments on Senate Bill 460. Though the intentions of the bill are commendable and it's indisputable that there is a need here, we agree with many of the points that the Maryland Insurance Administration made in their letter of information. You should have it in your bill file. But essentially, there are some provisions of this bill that imply that the program would assume the regulator's role or may be read as duplicative in some respects with both the Maryland Insurance Administration and the Health Education Advocacy Unit. We have some recommendations as far as language to sort of deal with those issues. The second issue is there is another provision that would require the MIA to produce potentially confidential information to a program that, despite their good intentions, is not a regulator. So that we'd like to take a look at that. And then the third piece is that there is a provision that could be read that the program is offering legal assistance. It's unclear what the scope of the representation might be if these individuals are attorneys. We just have questions around that issue. But we are broadly supportive of the intent of the bill. We just think the bill needs a little bit more work. I'd be happy to work with the sponsor and proponents to get it there.
Okay, thank you. Thank you for your testimony. Oh, Senator Beltman.
Just real quick, Neil, you signed up favorable with amendments. But we don't have anything in writing. Do you have amendments that you're contemplating, or you're just sort of leaving it?
I have some sort of conceptual stuff, but I'm happy to work with the sponsor to work that out.
Okay, thank you, Madam Chair.
Okay, thank you. That ends the testimony on that bill. I see Senator Lamb has come in, and so we're going back to Senate Bill 503. And let's see, I'll call up your panel. Deja Legans, Dr. Katrina Mark, and Pam Casemeyer. And the sponsors take the time that they need to lay out their bill, and others will have 2 minutes each. Okay.
All right. Good afternoon. Thank you, Chair Kelly, Vice Chair Feldman, members of the committee for the opportunity to introduce Senate Bill 503. For the record, Clarence Lamb, Senator District 12. The purpose of the bill is to help address the need for dualist services within the state, and it codifies existing MDH Medicaid regulations pertaining to doula services and reimbursement, which have been registered in their final form just this month earlier. Therefore, there's no fiscal impact as indicated in the fiscal note that just recently came out. I just want to remind the committee about the essential roles that doulas provide when in a healthcare setting. They offer emotional, physical, and educational support in the non-clinical aspects of childbirth, and care provided by doulas improves the pregnancy and birthing experience for women while also improving maternal and child health outcomes. They are a vital addition to the team of healthcare professionals assisting pregnant and laboring women. This bill recognizes the important and unique roles of doulas in our healthcare system. It helps create a clear and lasting policy and regulatory environment to encourage doulas to join the healthcare workforce and improve their partnerships with other medical professionals to support women and children, particularly in vulnerable and underserved communities. In line with the regulations, SB 503 requires a doula to meet specific professional requirements in order to provide doula services under Medicaid. In addition, the bill requires Medicaid to cover certain doula services that are medically necessary during the prenatal, labor, and delivery and postpartum periods of a birthing parent. By codifying the existing regulations, this bill establishes a permanent program for doulas to practice and receive reimbursement in the state of Maryland. The department was very helpful in ensuring that the regulations and thus the bill outlined the role of doulas, while also ensuring that it does not replace the roles of other healthcare professionals like obstetricians and nurses. One of the reasons the bills that are so important is because doula care has been shown to reduce adverse outcomes of childbirth, such as reducing the rate of C-sections, the rate of preterm deliveries, and the use of pain medications during delivery. Specifically, the research indicates that doula care is associated with a 22% lower odds of preterm birth, 28% in reduction of C-sections, 9% reduction in the use of pain medications during birth, 31% of use of synthetic oxytocin to increase the speed of labor, 12% increase in the likelihood of having a natural spontaneous vaginal birth, and also a 34% reduction in reporting a negative birth experience. And so there are also cost savings. The fact that doula care reduces birthing complications, including C-sections, as we mentioned, has shown that it has, under cost effectiveness model analysis, been estimated a reduction of $986 per doula-assisted delivery. In addition, doulas have been found to reduce the impact of racism and implicit bias in healthcare for pregnant individuals of color by providing culturally competent, patient-centered care and advocacy. In the U.S., black women are 2 to 3 times more likely to die of pregnancy-related causes than their white counterparts, and this statistic is only exacerbated further in Maryland as well, where we found that black women are 4 times more likely to die during childbirth compared to white men right here in our state. This statistic, from my perspective, is unacceptable, and we must put programs in place like this one to help address this inequity in maternal and child outcomes. 11 other states, including Virginia, Florida, Oregon, and California, have passed legislation to require Medicaid coverage of doula services. Like these other states, this bill creates a permanent pathway to increase access to community-based doula care that provides quality, culturally competent, and affordable care, leading to more equitable outcomes for women and children. This bill represents an 18-month collaboration between the Doula Technical Assistance Advisory Group and the Maryland Department of Health, Delegate Wilkins, and myself. We've purposely worked to ensure that our legislation codifies the existing program regulations, which have been negotiated for well over a year. They reflect compromise and contributions from various stakeholders, including the department, doulas, and mirror existing regulations to closely as closely as possible in order to make the structure of this program permanent, giving them the reassurance that this will have stability going forward, and also allowing the department to have the flexibility to run the program as they require it. So, for example, we have decided not to legislate the details of the doula reimbursement rates, which I know is a key factor and one for much discussion, in order to allow MDH to have future flexibility in these areas and to allow for fluctuations. In closing, there are sponsor amendments which are technical and clarifying in nature. These were requested by the department and accepted by the stakeholders that were needed to align better with the recently released and final version of the regulations. And with that, I'd like to thank my sponsor panels for being here today. Deja Liggins from Birth Supporters United, Dr. Katrina Mark from University of Maryland, Department of Obstetrics and Gynecology, and Pam Casemeyer representing MedChi and the American College of Obstetricians and Gynecologists. I'd like to thank the committee and ask for a favorable report.
Thank you. Senator Reedy?
Thank you, Madam Chair. Senator Lamb, I was just looking through some of the testimony, and there's been a lot of doula-related legislation the last couple sessions that I've been on this committee. MCOs came in with saying that this is somewhat duplicative with efforts underway on the health choice program. Can you comment on that? I know you said you've been working with the department. I mean, can you just comment on what they're talking about versus what we're trying to do here?
Yeah, I think the health choice program, I think, stems from efforts underway in Medicaid. And so there have been, there was a task force that was assigned that worked over the last 18 months in conjunction with the department and other stakeholders to come up with what we believe is part of this bill, lays the foundation and groundwork to ensure that doula services can be covered and that other details that need to be assigned through regulations can be done so by the department. So we were trying to lay down a strong foundation for doula services here in the state, and then be able to allow the department to be able to set up regulations when it comes to things like reimbursements for them and other things. But these...
would it also, not to interrupt you, would it also lay down professional, we're talking about mandating professional qualifications that under this, does your bill help to do that, or that's what they've been working on, is making sure there's a professional standard?
The bill articulates that there will be professional standards and creates, I think, like a certification program as part of that, but the rest of it is really left up to regulations and the department to be able to spell out. So what we're doing here is not trying to be too prescriptive, but laying down the proper underpinnings to ensure that doula services will be able to have sustainability as well as flexibility moving forward.
Because up until recently, it wasn't covered at all, right? I mean, Medicaid wasn't covering doula services basically at all, correct? I mean, until...
Right, it was a little bit haphazard. It depended on your payer and and the type of benefits coverage you had, and other people were basically paying out of pocket. And so this framework at least allows there to be further discussion and advancement of how the doulas can be reimbursed and coverage can be provided.
Okay, thank you. Thank you, Madam Chair.
Thank you. Senator Bidle?
Thank you, Madam Chair. Senator, there was a letter from the Nurse Midwives Association asking for a few kind of simple, straightforward amendments. Have you seen that?
We have seen that.
Okay, so will you be supporting that? Do you know yet, or?
I think we're open to discussion on that, but I think we have some, we wanted to make sure that the language in the bill aligns with the regulations that the task force and stakeholders had all agreed upon. Those adjustments would bring it a little bit out of alignment with the proposed regulations. And so that's why, we're taking a close look at it, but it's something that I think we will need to have further discussion on.
I just wanted to make sure you saw it. Thank
Yep.
you.
Okay. All right, thank you. All right, we're going next to Deja Liggins.
Good afternoon, everyone. My name is Deja Liggins. I'm here supporting Birth Supporters United and strongly urging in favor of Senate Bill 503. For many years, the Maryland maternal health space has addressed several different solutions in which our state can improve outcomes for the people and build their families in the state, for the people who live and build their families in these communities. As of last year, the state of Maryland has enacted an amazing first step towards addressing those maternal health outcomes as they relate to families that simultaneously battle disparities as a result of race and socioeconomic status. Senate Bill 503 is created to ensure that this solution that is both evidence-based and effective for the families giving birth and the medical care systems in place is something that continues onward in the future. Passing this bill will ensure that doulas, such as myself, will be able to contribute and continue to provide care to those who need the most. For this reason, Birth Supporters United is testifying in favor of Senate Bill 503. Thank you all.
Thank you. All right, we're going then to Katrina Mark.
Is this on? Yeah. Okay. Good afternoon. Thank you for having me here today. Thank you, Chair Kelly and Vice Chair Feldman, for allowing me this opportunity to testify today. My name's Dr. Katrina Mark. I'm an obstetrician and gynecologist, an associate professor at the University of Maryland School of Medicine, and I'm here on behalf of myself and the Department of Obstetrics and Gynecology to testify in support of this bill. I've also provided written testimony that outlines the evidence base and cites literature and references that discuss the medical benefit of doulas and trained birth support. But really why I wanted to testify in person today was not just to list a bunch of citations and give you the medical evidence, but to give you my personal experience and to really just highlight the importance of this bill in allowing equitable access to this care. So part of what I love about my job is that I get to take care of people from all different walks of life, from different races, creeds, religions, backgrounds, and socioeconomic statuses. But really, the very heartbreaking portion of my job is that I see firsthand every day the inequitable access to care and how that affects mothers. I work in West Baltimore, and so I really see the racial divide and inequities that occur in healthcare every day. We know that doula services are beneficial, evidence-based, they're financially, they make sense, and they improve maternal and child outcomes. These services are being accessed by Marylanders, but only the Marylanders who can afford to pay for them. And those aren't really the people that are benefiting the most from them. Until now, these services have really been inaccessible to the people who would benefit the most. The question today, in my mind, is not, are doula services beneficial, but rather, who do we think deserves these services? So I urge you to support Senate Bill 503 and allow more equitable access to doula services to the pregnant people of Maryland who will benefit from them the most.
Thank you. Let me just ask one question. If you had to answer that question as to who would benefit most, could you give us a kind of succinct idea of how you would define that category?
I would say the people who experience healthcare disparities the most and need a voice and empowerment, and those who have low health literacy as well, I think would benefit the most from these services.
Thank you. All right, we're going next to Pam Casemeyer on behalf of MedCot.
Hi, Madam Chairman and members of the committee. Pam Casemeyer here on behalf of MedCai and also the American College of Obstetricians and Gynecologists, who really sort of were the lead in the physician community in working on this issue. And I'm not going to add much to the substance that was said, but I really wanted to provide a little bit of clarification. You heard another doula bill a week or two prior. The history behind this whole process of getting to where we are now, there was a doula bill in, I think, 2 years ago, had a lot of provisions that everyone who was supportive of doulas were sort of concerned about the provisions of the bill. That's where the stakeholder advisory group was set up, and all of the stakeholders worked for the last 18 months to put a framework together. Late this fall, regulations were proposed that were consensus regulations that everyone agreed with. This bill reflects that outcome. The other bill, in fairness, was not intended not to, but has a lot of detail in it that is not usually found in statute, like rates of payment and lists of things that are usually left for regulation, because as you well know, if you need to change something, it's harder to change it in the statute, or if you need to adjust stuff than it is in the regulations. So we're very pleased to see this bill, which really lays the framework that everyone agreed to, and a statute that makes the permanent program, but is and aligns with the regulations. The regulations have now been finalized, and I think, Senator Reedy, to your question about the MCO's issues, and Medicaid is rolling it out. But I think when this bill was first put together and the stakeholders were finishing the regulations, it hadn't been done, and Medicaid is implementing it. So some may say, well, we have regulations, so there's not a statutory need, but this really dovetails with the regulations, even as the program is rolling out, to make sure going forward there's clear structure for what this program looks like. So just a little bit of clarification of the process issues and why we are now here where we are. And then the last issue, I think, with respect to the additional amendments that you raised, Senator Bidel, they fortunately, and this bill was heard yesterday in the House, and that question came up as well, and there's already some conversation how to fit it in, and I think everybody believes it gets fit in. It's intended to be more clarifying than anything, in part because I think we need to reassure people that these are not clinical providers, they're support providers, because that's created a little bit of churn, and so we're sorting through that, and I think at the end of the day, everything will frame with the regulations.
Thank you. That was very helpful. Okay, and we're going next to Scott Tiffin.
I think he may be over in the house.
Oh, all right. Okay, let's see. Did we get from Kimberly Haven? All right, Kimberly Haven. Is Kimberly in the room? Maybe she's testifying in the House also. Well, this panel was very good. You gave us a lot, and I think it was very clarifying. Okay. All right, so that ends the testimony, and we will go next. All right, Senator Augustine, 590. And you have the time that you need to lay out the parameters of your bill, and then all of your panelists.
This one's just me, Madam Chair.
All right, good.
All right. Senator Augustine here on behalf of Senate Bill 590, Public Health Behavioral Risk Factor Surveillance System Requirements. Colleagues, you know that I've really concentrated a lot of my work, I've looked very closely at both positive and adverse childhood experiences. There are different elements to this. Earlier in this session, I came before us that dealt on the more of the clinical level. What this bill looks at is the public health aspects of adverse childhood experiences. Last year, I had a piece of legislation that made sure that when the Youth Behavioral Risk Survey, which is a survey that is done with youth that asks questions about, again, certain risky behaviors or risk factors or things that are happening in their life, that we're able to then calculate and keep together so that we're able to make good public health decisions. I made sure that when we were doing that, we were asking questions about adverse childhood experiences on a regular basis so that we would be able to have longitudinal data over time to be able to really measure how we're doing at reducing adverse childhood experiences, because there is a direct causal linkage between adverse childhood experiences to negative behavioral and somatic health outcomes for people. This is a companion to that. This piece of legislation is a companion to that, in that, as a state, we have a behavioral risk factor surveillance system, which is done by phone, where it asks 10,000 Marylanders across the state similar questions, but this is about the adults. Now, in talking with the department, who have been asking questions around adverse childhood experiences, what we talked about, though, was what is the appropriate time for adults that we should be asking similar questions that allow us to get longitudinal data that we can use for public health decision-making around adverse childhood experiences. And that's what you see before you in this bill, which asks for a cadence of making sure that every 3 years we are asking adults in order to see how we're doing as a state with regard to adverse childhood experiences. The reason to put it into statute is so that we can make sure that we get that data over time, and that we're going to have that consistent data set that we can look at. They have done some interesting things in California, where they have set a goal of cutting adverse childhood experiences in half in a generation. Something that I seriously aspire to, and I'm hopeful that we can start to look at here in Maryland. But this is a first step where we at least are collecting and having the information so that we can go about making those changes with regard to behavioral health outcomes. And so I ask for a favorable report on Senate Bill 590. Thank you.
Thank you very much. Are there any questions? Okay, thank you. All right. We're going then to Senator Sidnor, Senate Bill 350. And Senator, let me call up your panel members. Dr. Kyle Fisher, James Timpson, Martha Nathanson. Okay. And when there's a place at the table, we'll add Brian Sims. All right. Okay. All right. Senator Sidnor, you may go ahead and start.
All right. Thank you.
You have as much time as you need, and your panelists will have 2 minutes each.
Okay. Thank you very much, Chair Kelly, members of the Finance Committee. You have my written testimony, so I'm not going to read from it, but I'm going to reference it. Last year, the Biden-Harris administration, in their efforts to attempt to stem community violence throughout the United States, they made a pronouncement that they wanted to make certain that there were ways that Medicaid could be used as a way to dampen community violence. So what they did is they said that they wanted Medicaid to be able to be used for certain violence prevention programs. One of the first states to take advantage of that was the state of Connecticut. And you'll hear later from Mr. Fisher about his efforts in Connecticut to pass legislation in Connecticut to do just what this piece of legislation essentially is intended to do here in the state of Maryland. With so much violence that has been happening across this state, the city of Baltimore namely, where you're talking about 300 plus homicides over the past few years, that type of violence has adversely affected a number of our communities, not only by the people who have been killed, but by the families that have been left behind, the families that have to live in those communities constantly under a threat of violence. Within my testimony, I talked about how hurt people hurt people. What these community violence intervention programs are about intervening, making certain that those people who have been hurt are provided to their, in whatever ways that they need to be to kind of stem that violence. So, as I mentioned, Connecticut has done this, the state of Illinois has done this, and what you're talking about, and again, maybe Dr. Fisher will mention, but there have been some research that's been done where you're talking about $69 million annually in violent re-injury costs being certainly substantial. So anyway, what this bill does is, again, it makes a pool of money available for these programs, whether it be hospitals or whether it be programs like ROCA that are outside of the hospitals, makes it available so that funding is stable and reliable so that these organizations and these types of programs can continue to support the really good work that they do. I'm going to be quiet now and let my panel kind of talk about the research and things that they've done. So if Mr. Fisher.
So Dr. Fisher?
Dr. Fisher.
Thank you very much. Thank you, sir. Madam Chair, thank you for having me here today. I'm Kyle Fisher. I'm an emergency physician with the University of Maryland and the policy director for the Health Alliance for Violence Intervention. I'm speaking favorably today about SB 350, both on behalf of the emergency physicians and the HAVI. The HAVI, we are the National Network of Hospital-Based Violence Intervention Programs. We have about 50 member programs around the state, around the country, with shock trauma being one of our founding programs. Our programs are an integrated, coordinated care model for caring for violently injured patients to make sure that they heal fully, both physically, mentally, and to reduce the risk of being injured again or retaliating against other folks. We found that over the years that this model works. People have better mental health outcomes, they don't get re-injured, they don't retaliate against other people. And in doing this work, it is highly dependent on the frontline workers that do it, that we call violence prevention professionals. These are folks that predominantly have a history of being exposed to community violence in the past or may have been victims themselves and have gone through to the other side and have healed and been trained and certified to deliver those services and help others heal. The model is about 25 years old, and like I mentioned, we have built up systems of care for best practices, standards of care, and the training and certification, and have gotten recognition at the national level from both the National Uniform Claims Committee, recognizing these healthcare providers, as well as the Senator mentioned, the Centers for Medicare and Medicaid Services last year outlined ways that states can use this for benefits. You might ask why use Medicaid for gun violence, and the reality is that for folks that have been injured by gun violence, Medicaid is the de facto connection to the healthcare system. It is the #1 payer of all the healthcare-related costs for gun violence. And sadly, if you look at the #2 payer, it's uninsured. So it really is the only game in town. So with that in mind, Medicaid is a very valuable tool to help this patient population and to bridge this model of making public health approaches towards violence real and not theoretical. Looking at it even a different way, the Medicaid program is responsible for these costs if you do anything or not. So it makes sense to do this proactively so that Medicaid is preventing injuries in the future and saving money in the long term. And like the Senator said, I did work at a number of levels with gaining the recognition through the National Claims Committee, working with CMS and the Connecticut implementation, as well as California now. So I'm happy to answer any questions that anyone may have. Thank you.
Okay.
And Madam Chair, I meant to say, and I forgot, and I wanted just to make certain that this body was aware. The idea of this bill, it actually stemmed from a conversation that I had had with my colleague at the time, former delegate Eric Barron, currently our U.S. Attorney here for the state of Maryland. This was something that I believe that if he still was with us here in the legislature, he would have been championing. But since he moved on, I told him that I wanted to take this on with him, for him. Thank you.
Thank you. All right, we'll call next on James Thompson. You have 2 minutes.
Good afternoon, Madam Chair, Vice Chair, and the esteemed committee. Thank you for the opportunity to take this time to speak to you. My name is James Thompson. I'm the Director of Community Partnerships and Safety for Roca, Maryland, in Baltimore. And I've been with Roca, Maryland for about the past 3.5 years now in that capacity. We've been doing this work for about 35 years in the state of Massachusetts originally, before we came to Baltimore almost 4 years ago now. And a lot of that work has helped us be able to really align the way that we do this violence prevention work. We really use brain science and relentless outreach to really support our long-term behavior change for the young people that we deal with. We're a behavioral health model that deals with young men ages 16 to 24 years old. And the goal, again, is really to help them really have a sustained behavior change. In Baltimore, in 2021, we served 240 young men. More than 80% of the participants actively practiced and applied our cognitive behavioral therapy, or CBT, which helped more than 4 or 5 of the participants in the group realize measurable improvements in their behavioral health. Nearly 90% participated in educational, vocational, life skills, and or transitional employment programs. And among all those enrolled in the program for 2 or more years, more than 80% have no new arrests. So those are some numbers that we really are really proud of. In addition to reduce the retaliatory violence, we implemented a citywide after-shooting protocol for victims of non-fatal shootings that have resulted with 40 new enrollments into our program as a result of that. In 2020, Maryland had the 9th highest homicide rate in the nation, and in keeping with national trends, the number of murders spiked in several Maryland jurisdictions, including Prince George's County, Montgomery County, Baltimore County. A lot of the surrounding counties saw upticks. So we think that with this Medicare bill, thanks to Senator Sidnor's leadership, we have the opportunity to join Connecticut in leading the nation forward and violence prevention by passing this groundbreaking legislation. One of the things that we know is, first, by expanding Medicaid to cover violence prevention, it would be a wise financial investment for the state. Currently, the cost associated with violence prevention programs is paid by the state and local governments. As you know, the state splits the cost of Medicaid program with the federal government, so the bill would relieve the state of half the cost of violence prevention services. As a result, the state could, if it wished to do so, double the size of violence prevention services without increasing the state budget. Secondly, or another thing is that the increased investment in effective violence prevention programs will create cost savings within the Medicaid program. In 2016, more than $1.1 billion was spent in the United States for health care to treat shooting-related injuries, and half that cost was covered by Medicaid. And of course, we all understand that health care costs have increased significantly in the past 5 years. If we can engage more young men who are at the highest risk to shoot or be shot to teach them actively to use CBT, we can save lives and save the Medicaid program a lot of money. Lastly, SB 350 provides an opportunity to elevate and enhance prevention. We should recognize violence prevention for what it is: behavioral health services for high-risk young people who have experienced significant trauma and typically struggle with a range of other challenges that increases their vulnerability, including homelessness, substance abuse, challenged educational systems, high rates of unemployment, and gang involvement. Unless we can address all of those different elements of what these young people face, we're going to be in for a long battle ahead. So we respectively suggest that it's time that we treat violence prevention as a critical behavioral health service that changes behavior by giving young people the skills to think, feel, and act differently. The invitation the state of Maryland has received from the federal government to leverage Medicaid for violence prevention provides an unprecedented opportunity to build a much-needed behavioral health workforce and provide more resources and training for those working on the front lines to engage the most disenfranchised and traumatized young people and reduce levels of violence and save lives. Thank you again for.
Okay, thank you.
the
We
opportunity.
generally have 2-minute rule, but, you know, that was excellent testimony. We're going to go next to Martha Nathanson, and
Yes.
I'm going to put you on the 2-minute clock now, though.
That's fine. I
Okay.
hope to take less since so many of my points were made, and he is the toughest act to follow, so I will try to make it short because of that. I'm Martha Nathanson, Vice President, Government Relations and Community Development for LifeBridge Health, a hospital system that serves the Central Baltimore region, and I'm so pleased to see 3 of our members here who serve the same area that we do. So. You all are very familiar with the community health needs assessments that hospitals are required to do every 3 years as part of the Affordable Care Act. Our first CHNA, our formal, very intensive community needs assessment, was done in 2015, and one of the highest ranking community health needs that were identified, in addition to the usual diabetes, heart disease, cancer, was violence. People in our communities are concerned that violence is negatively impacting their health. So we went to work very quickly beefing up our legacy programs around domestic violence and child abuse to enhance our community violence intervention strategies. We've since done a couple safe streets programs and a hospital responder program. And then in 2018 and 2021, our next round of triennial community health needs assessments, same result. Violence was still a key concern for our communities and the impact upon their health. So we continue to increase that level of programming, but those are really funded through grant funding and through philanthropy and operating funds. So having this Medicaid reimbursement source of funding will ensure that this can be continued. Obviously, you've heard hospitals treat victims of violence already through the most expensive settings like our ERs, our ICUs, our surgery, and our rehab. And clearly, I can support the concept of it as a behavioral health issue as well, and those are very expensive to serve as well. If we look at the fiscal note, I think this bears more discussion beyond today, but it appears to be high with some statistics that appear to be more nationally based. Would that we would be able to treat this many victims in Maryland. There probably are this many, but
It doesn't seem that the universe is as big, so I think the fiscal note should come in lower, and we will get back to you on some of that information. To close up, what a small price to pay to respond to the needs identified specifically by our communities and to also keep healthcare costs down. With that, I conclude.
Okay, thank you. We're going to open up questions from the committee, starting with Senator Hayes.
Thank you, Mr. Vice Chair. First, I'd like to take a personal privilege. James Thompson and I have worked with each other for years. His work around violence prevention in the community is extraordinary, and, you know, I appreciate and welcome the Senate Finance. On the other hand, to the sponsor, and I apologize if I missed it, I was wondering why you left in the middle of my hearing. You had to come up here to my committee. And so, you know, and thank God I'm back home in Senate Finance. My bill was the second bill on the agenda, and it took almost an hour. But no, with all due seriousness, Mr. Sponsor, I think this is a brilliant piece of legislation. We've looked at Medicaid for reimbursements as it relates to, you know, living in place and other different things. I think this is a really creative way to acknowledge that violence in our community is a public health issue and that we need means to sustain it and prevent it. Do we know of any other states or any other any places where they may be looking at you know, this as a potential source of funding?
So the short answer is yes. Connecticut and Illinois. Dr. Fisher, in fact, I'll let him respond because it's been one of his brainchilds.
Sure, yeah, I'll say I started working on this about a decade ago when I was working with the Healing Heart People program up in Philadelphia, and have been working on building out the infrastructure to actually do it over the last decade. So I'm very excited to be here today and hope that we can bring it home here to Maryland. So the first program to ever do it was a single program through a waiver in the city of Philadelphia. And then after the CMS guidance came out last year, Illinois and Connecticut both did it quite quickly through legislation. Subsequently, as we speak, you all are considering it. Yeah. The state of Oregon has a bill moving through the legislature right now that their Speaker of the House introduced. And just about 2 weeks ago, the state of California, through an administrative action through their Department of Healthcare Services, is planning on putting in a state plan amendment to add in the benefit through their existing community health worker benefit. So there are a number of states that are doing it. I'm fielding a lot of phone calls as well of states that are starting to think through how they might do it as well.
Thank you for that response, and you've already answered my second question, because I know sometimes we could do it through waiver or through legislation, and it's kind of, it seems like there's a mismatch in how they have gone about achieving this. The other question that I had in this regard was there is some testimony that was submitted. I'm not sure if you've had the opportunity to look at all of the testimony that's been submitted in support and unfavorable or, you know, the new work of art is information that they provide to the committee, express some concerns about implementation of this. In looking at the legislation that's before us now and what has been done in other states, I guess, do you see, or what assurances that you could give us that implementation is described? And I'm not sure if you had a chance to see some of the letters of information, and we could maybe answer it sometime. But I'd be curious in our deliberations to have a better understanding of what challenges we may have in implementing it here in Maryland. Thank you, Mr. Vice Chair.
Thank you. We're going to go next to Senator Augustine.
Thank you, Vice Chair. And this actually dovetails with what Senator Hayes was saying. It's just a little bit different, but it is the same. So what I would ask from the sponsor and from the from those who sort of know this, it would be there's the question on the implementation, but there's also just a question of, for lack of a better word, like the results of what has occurred in the other places that have thus far been utilizing it. It's not to be answered today, but I think that that is important because this is important. I mean, this is important work, it's stuff that we need to do, but there's just a lot of demands on Medicaid dollars. I mean, there really are. So we really do need, I think it would be important for us to see how that has, the success of the program, particularly in those other places. So I'd appreciate just if you would share that with us in the whatever, as soon as possible. Okay? Thank you.
Okay, any additional questions for the panel? Okay, seeing none, we had one other witness as part of your panel, Senator Brian Sims. So you guys can maybe retire back to your seats. We'll let Mr. Sims come up, and while we're at it, we did have 2 additional witnesses signed up, not formally part of your panel, but we'll bring them up anyway. Lisa Jones and Shante Jackson, both signed up favorable. So, Mr. Sims, we're going to lead with you, and as I said earlier, we're going to go by a 2-minute rule that we normally go with. Okay?
Sure, and I'll try to make this quick. Good afternoon, Mr. Vice Chair. Madam Chair is not here anymore, and committee members. I want to thank you, Senator Sidno, for bringing this crucial bill to the floor here. My name is Brian Sims, Director of Quality and Health Improvement at the Maryland Hospital Association. And on behalf of our 60 member hospitals and health systems, I appreciate the opportunity to comment in strong support of Senate Bill 350. As my colleagues who were up here earlier said, community violence affects thousands of Marylanders, and the deep physical and mental wounds that this violence leaves behind is a major public health problem. And while we, the hospitals, play an important role in providing care to victims of violence, ending the cycle of violence is a priority that we share with the many community-based organizations that have engaged in these prevention efforts for decades, as you heard one of our colleagues earlier speak to. Hospital-based violence intervention programs and community violence intervention programs are critical in this fight and must be adequately funded to meet the needs of the community. And, beyond the individual well-being, community violence adds immense economic costs to the health system, and this is something you heard about a second ago. And that cost that this adds to the health system far exceeds the cost of the prevention efforts that we're talking about here today. Medicaid is often, as Dr. Kyle said earlier, often financially responsible for the state's high levels of violence in serving those who've been victims. And Medicaid can offer a predictable and reliable funding source. And the integration of violence prevention programming in the traditional healthcare and financing systems would represent a significant shift in the state's response to violence. We know what things can work to stem violence in our communities, and like strategies employed during the COVID-19 pandemic, a well-funded public health approach is necessary. And now is the time to adopt sustainable long-term solutions to address community violence and help our communities heal and attempt to break the cycle of violence. And for these reasons, we urge a favorable report on SB 350. Thank you.
Okay, thank you, Mr. Sims. Why don't we go to the final 2 witnesses, and then we'll come back for any questions. Ms. Jones.
Good afternoon. My name is Lisa Jones. I am the director of the Community Violence Intervention Programs for LifeBridge Health Center for Hope, which is among the first of a kind of a violence prevention program in the nation. I have over 25 years' experience as a person dealing with violence intervention programs. I am here to testify about the importance of Senate Bill 350. I want to share a story with you. Like I said, I've been doing this work for a long time. During this work, I met a young lady. She was a high-ranking member of a gang. She saw her brother killed on the street. She saw a friend wounded terribly. The friend went to the emergency room and was met at bedside with a responder. The person that was killed on the street was her brother. She worked with the violence interrupters. They met with her around the clock to prevent the mitigation of continued violence. As a result of the relationship that she built with the interrupter, she became the advocate for the program. She prevented most incidences that happened in her neighborhood. As a result of making the connection with the interrupter, she became an interrupter herself. She changed her life and changed the trajectory of the places in her community. As a result of that, the person in the hospital changed his life. I am here to say, please support the Senate Bill 350.
Okay, thank you, Ms. Jones. We're going to go to our final witness, Ms. Jackson.
Chair, Vice Chair, members of the committee,
Thanks for having me before you today. My name is Shantae Jackson, and I'm the Director of the Mayor's Office of Neighborhood Safety and Engagement for the City of Baltimore. I come before you today on behalf of Mayor Scott and the Baltimore City Administration in strong support of Senate Bill 350. I'm not going to repeat what you all have already heard, but I will say that Mayor Scott and I firmly believe that Maryland needs to be on the forefront of this work associated with hospital-based services to prevent and intervene in violence in our communities, because we know that injured patients, more than 50% of them or their family members, retaliate in Baltimore City. Having completed a recent problem analysis in the Western District, which between 2015 and 2020 resulted in 818 shootings, we know that the vast majority of those were retaliation-based because of victimization or poly-victimization as a result of these individuals' life circumstances. The Office of Neighborhood Safety and Engagement, along with the mayor, the health commissioner, the police commissioner, Mr. Barron and others, met with all of the chief medical officers of the medical systems in Baltimore City just on February 1st, and they've all expressed strong support and interest in making sure that we're partnering together to develop a very robust community violence intervention ecosystem that involves hospital-based response in ways that are more coordinated than they've ever been before in our city. I'm happy to answer any questions that you might have.
Okay, thank you for your testimony. Any questions for the panel? Seeing none, that concludes the bill hearing on Senate Bill 350. We're going to now shift to Senator Hayes.
Thank you very much.
Senate Bill 607.
At the table or
It's
podium?
totally up to you.
All right, awesome. Is Mark here? Mark, you want to come on up? Good afternoon, Mr. Vice Chair, members of the Senate Finance Committee. Senator Antonio Hayes, for the record. I bring to you Senate Bill 607, Health Equity Resource Communities Modification.
And Mr. Sponsor, just real quick, Senator Hayes. So we've got Mr. Lochner and you're Dr. Carter. One other person on your panel, let's bring her
Yes,
up, okay? So
indeed.
now we got your whole panel.
No,
Okay.
no problem. I
Okay, back
appreciate
to
it.
you, Senator Hayes.
Yes. As this committee knows, last year we passed a really important piece of legislation, the Health Equity Resource Communities, which address health inequities across our state. This was, a pretty big milestone and one of the proudest moments that I've heard to serve in this body. But in doing so, the commission, which Mark here served as the executive director, and the actual implementation of this legislation that we passed, recognize that there's a couple of minor changes that we need to make, and so that's what brings us to you here today. So I'm pleased to introduce Senate Bill 607, which make modest program adjustments to the Maryland Health Equity Resource Program, a landmark 5-year program that was approved by the Senate unanimously to reduce health disparities and to improve health outcomes in underserved communities. This bill was approved last year by Senate Finance unanimously and Senate Budget and Tax, and I'm very happy that leaders from both committees have signed on to this piece of legislation this year. The bill that I'm introducing, Senate Bill 607, is a simple and straightforward bill that makes modest improvements that have been requested by the Maryland Community Health Resource Commission as they implement the Maryland Health Equity Resource Act in the 2 years of the program. There is no fiscal note to the bill, and the bill would enable the CHRC to utilize the HERC fund in FY23 budget to cover the staffing costs of 2 pens that are already included in the governor's budget for FY23. The modifications presented in Senate Bill 607 will require Chesapeake Regional Information Systems for our patients, which we also often refer to as CRISP, to provide technical assistance to the Community Health Resource Commission as it implements provisions of the law governing health equity resource communities. Senate Bill 607 also proposes that to alter the date by which the Commission must issue a request for proposals to designate areas of health equity resource communities. By extending the deadline, more communities will be able to benefit from the changes being implemented through the Health Equity Resource Committee's law. Mark Luckner, CHRC Executive Director, will be following my testimony to describe Senate Bill 607. I'm pleased that HCRC is moving forward expeditiously to implement the Health Equity Resource Act, and they issued the first round of grant awards just last week. I understand that non-initial grantees have been selected by the CHRC, and 2 of these new grantees are here today to speak in support of Senate Bill 607 and describe how they will utilize the new funding made available by the Maryland General Assembly to reduce health disparities and improve health outcomes. Dr. Ernest Carter from Prince George's Health Department and Yolanda, Lady O, I'm not going to butcher your name. You can help us out a little bit later, from the University of Maryland School of Nursing. I also have a technical amendment that will allow for the funding of the project director to be taken from the HERC fund and further clarify that the 2 other full-time positions will be funded through the same fund. Ladies and gentlemen, colleagues of Senate Finance, I urge a favorable report for Senate Bill 607.
Okay, before we go to the panel, any questions of Senator Hayes, the sponsor? Okay, seeing none, thank you, Senator.
All right.
We'll go to Mr. Luckner next.
It's good to see you again, Mr. Vice Chair. Mark Luckner, Maryland Community Health Resource Commission. Senator Hayes, thank you very much for introducing Senate Bill 607, and thank you also for introducing last year's bill. It's a great pleasure to work with you. You've been very involved at every step of the way, and thanks again for introducing this bill. As you said earlier, the commission announced 9 grants totaling $13.5 million. 2 of these new grantees are sitting to my right, and they'll talk for a minute. But of the 9 projects, 3 are from Baltimore City, 3 are from Prince George's County, and 3 are in rural areas. 1 from the Lower Shore, 1 from Washington County, and 1 from St. Mary's. Of those 9 projects, I recall that this bill was approved by the committee, and prior HEZ support was important. So 5 of the 9 projects serve geographic areas under the current project. I see you pleased to hear that. The bill, as Senator Hayes said, does 3 very simple things. Number 1, it pushes back by 12 months the date for the next RFP from October 2022 to October 2023, which will allow Dr. Carter and Yolanda to have more time to implement their 2-year projects. Second, it allows for those PINs that are in the governor's budget to be derived from the HERC fund, which takes effect July 1. And then third, it allows us to enter a second contract with CRISP to help us evaluate the project in the HERC fund. Those are the 3 things in this bill before you, and thanks again for the technical amendment that you're putting in as sponsor. With that, I'd be happy to answer any questions, and before I conclude my formal testimony, I just want to give Senator Kathy a very happy birthday request. I know she's out of the room, but happy birthday to Senator Kathy.
2/22/22 birthday girl. Okay, why don't we go through the other 2 witnesses, and we'll loop back for any questions. So we're going to go with Dr. Carter next, and 2 minutes, if you can.
Thank you, Mr. Vice Chair. Members of the Finance Committee, thank you for the opportunity to share with you today some of the successes we had in Prince George's County as it relates to the legislation that is going to happen and related to a health enterprise zone. The Prince George's County Health Department was one of the entities funded by CHRC for a health enterprise zone project, the precursor to the Health Equity Resource Community legislation. I included more detail in my written testimony, but will share 3 quick highlights with you today. The Health Enterprise Zone created an effective value-based system of care in zip code 20743, which has about 40,000 residents and is severely underserved. Through the Health Enterprise Zone, we did 3 things. 1, we developed a population health management model, including care coordination, community health worker services, and expansion of primary care medical homes that now serves as a basis for all of the health department's work. We improved access to high-quality primary care, including 58,451 patient visits in the Health Enterprise Zone medical practices. And third, we reduced hospital costs by an estimated 30 to 54%. I'm happy to report that we were recently awarded a Pathway to Health Equity grant that will expand on the work of the Health Enterprise Zone to implement this model across high-need zip codes in Prince George's County. This transformational work would not be possible without the HERC legislation and the work of the CHRC. So on behalf of the county, I would like to thank everyone who has contributed to these efforts. Thank you to Senator Hayes, Director Luckner, for inviting me to speak today, and thank you to the committee for your continued commitment to health equity for all. Thank you.
Okay, thank you, Doctor. We'll go to our final witness. Sponsor referred to you as Lady O. I'll try to, I think it's Miss, Ogbolo Lou, and I probably botched it up too. So, in any event, 2 minutes.
Sure. Thank you so much. My name is Yolanda Obalu. I'm an associate professor and director for the Center for Health Equity and Outcomes Research at University of Maryland, Baltimore in the School of Nursing. I'm also a native and product of West Baltimore, which drives my passion for health equity. I'm here today to represent the West Baltimore Rich Collaborative, which was recently funded with a Pathways to Health Equity grant. And also many of the organizations that are part of the collaborative were part of the prior HCC. Our collaborative focuses on heart disease. We know that heart disease is the leading cause of death all over the world, but in Baltimore City, it accounts for 24% of deaths. And the 8 neighborhoods that we will be working in have higher than the state average rates of heart disease. Further complicating heart disease is social isolation. All of you became familiar with that as a household word during the COVID pandemic. But in Baltimore, people are isolated not only from each other, but from social resources that they need for health. Social isolation is important because I'm not sure if you're aware, but it is as dangerous as smoking, and it is associated with heart disease, which is why I'm talking about it today, particularly for middle-aged adults. In West Baltimore, we seek to implement key interventions, which the first is the development of a health equity learning collaborative. It's a group of organizations that are hospitals, community-based organizations, faith-based organizations, academic institutions, hospitals, and federally qualified centers that are providing care to West Baltimoreans, and we will work together to strengthen that work. We will implement nurse-led clinics, mobile health programs, and a community health worker program that will address social challenges that the residents face. In closing, I'm very grateful to this committee, to Mark Luckner, to Senator Hayes, to Shirley Nathan Pulliam, for all of the work that Maryland has been doing as it relates to health equity. And I thank you for allowing me to testify today.
Okay, thank you for your testimony. Mr. Luckner, I'm going to maybe just throw 1-2 questions. So, you know, obviously the committee's now invested in wanting to have this work. So just talk real briefly, you know, there was a prior iteration of conceptually of what we're trying to do here. What kind of lessons can you, because your commission at that time was very much in the middle, what lessons did you draw about some of the problems the last time around so that we don't make the same mistakes again? You have firsthand knowledge. And I guess secondly, just looking ahead a little bit, you know, what other kinds of tools do you think you might need down the road to make this work? Again, I think we're invested to make it work, but it'd be good to sort of hear from you, lessons learned, looking ahead. So I'll just kind of open-ended question, but I think they're important questions.
Sure, thanks for that. So I guess the first thing I would say is the outstanding quality of the Maryland Health Equity Resource Act that this committee approved with the members of the Senate Budget and Taxation Committee. You provided 5 years of funding, perhaps more down the road, and that exceeds the first amount of funding that was made available in the first program. The second thing that was so outstanding about Senator Hayes' bill last year is it's very clear. You pick one regulatory agency to run this program. It wasn't a bifurcated structure like occurred 2 years ago. So kudos to you for recognizing that. We appreciate the vote of confidence. Third, we learned that you can't run a huge program, which is a whole new program, with one pen, right? You know, there's 5 pens in my office, right? That's crazy. So thanks to your bill and another bill that Chairman Gazzoni put in, there's going to be sufficient funding for this for our office. So we have 5 new pens that are going to be coming online in the next year. The first of which we received 40 resumes for the HERC project director, and those are under review right now, and hopefully that person will start by session. So we're adequately staffing up. And then the other comment I would make is we learned that it took too long for those of us at the state level to articulate the key metrics. That's on us, right? We should have done a better job with the Health Enterprise Zone project. There's a lot of blame to go around. So when you all were working on Senator Hayes' bill and the House cross-file last year, the first amendment that I wanted in the bill, the very first one, if you recall, was writing CRISP into the bill. So CRISP is written into the bill. We're pleased to have a 2-year contract with them. And part of this bill here before you is to allow us to work with them on a second contract as we work on the HERC part of the bill. So Senator Feldman, thanks for the question. We learned a lot, and we tried to do our best to anticipate some of those things in the bill you approved last year. And there's some more modest tweaks here and there in the bill that Senator Hayes before you today.
Okay, thank you, Mr. Luckner. Any other additional questions for, I see Senator Benson trying to put that button on. Senator Benson, there you go.
Yes, thank you very much, Mr. Vice Chair. I want to thank Senator Hayes for putting this bill in. As Dr. Carter has indicated, zip code 20743 is a great concern for us in Prince George's County because it is known as a health enterprise zone and a food desert. And I know that, and I want to commend Dr. Carter for the work that he has done in Prince George's County as our health officer. As you will see, there's been a wonderful decline in the number of cases, of COVID cases, and more people are getting the booster shot. And I just want to say thank you for the work that he has done in Prince George's County. I'm just wondering, Dr. Carter, what more can we do other than this bill to give you the kind of support that's necessary for us to continue to raise the bar for the health and welfare of the people in those zones that Senator Hayes is talking about?
Thank you for that question, Senator. I will tell you that this is a great start. The Pathways to Equity is a great start. And from that, we learn lessons to how we need to build it because every community is unique, as you well know. And we learned a lot from the Health Enterprise Zone about how we need to build the infrastructure. So each community has certain unique needs. And what we will do is, as we go through this grant, this Pathways grant, we will start to identify those things specifically in those zip codes that we have and the surrounding zip codes, and then how that applies to the rest of the state. So I hesitate to say now what we need, because I know we're going to discover so many things with this particular grant.
Okay, any additional questions for the panel? Okay, seeing none, that concludes the bill hearing on Senate Bill 607, and I'm going to yield it back to Chair Kelly for our final 2 bills.
Okay, thank you. We're going next to Senate Bill 659, Senator Benson. And I'm going to call up your panel members, Dr. Harsh, Trivedi, Jennifer Wilkinson, and Dr. Todd Peters. As always, the sponsor will have the time that he or she needs to lay out the parameters of the bill, and then everyone else will have 2 minutes each.
Thank you very much. Thank you very much, Madam Chair, Mr. Vice Chair, and members of the Finance Committee. I would like to present for your consideration Senate Bill 659, Maryland Medical Assistance Program, Psychiatric Inpatient Care Admissions Restrictions. This legislation is pivotal in protecting some of the most vulnerable in our society from the cost associated with mental health care. As we all know, mental health has been at the forefront of many topics lately, mainly for good reasons. It is no longer taboo and should be treated with the same care and sincerity as any other bodily function we visit the hospital for. Mental health affects how we think, how we feel, and act as we cope with life. At times, these things may not be in unison, thus affecting how we function in the world, and therefore becoming an unhealthy bodily function that needs special medical treatment, just as any other injury or health issue you may visit the doctor for, and the Maryland Medical Assistance Program helps cover. Maryland Medical Assistance Program should treat psychiatric inpatients' care no different. The purpose of this bill is to prohibit the Maryland Department of Health from limiting or restricting admissions of a Maryland Medical Assistance Program recipient for inpatient care at a particular psychiatric hospital or an acute general care hospital with separately identified inpatient psychiatric service, except under certain circumstances and generally relating to restrictions on admissions for psychiatric inpatient care and the Maryland Medical Assistance Program. To improve behavioral health in our society, we must start by allowing access to coverage by those affected. This bill will help patients who require mental health assistance do so and not be bogged down by the hospital fees and have coverage. And so therefore, I respectfully urge the committee to issue a favorable report for Senate Bill 659.
Thank you. Are there any questions? Okay, then we'll go to the panel, and we'll start with Dr. Harsh Trivedi.
Thank you so much. Madam Chair, Mr. Vice Chair, members of the Senate Finance Committee, thank you for the opportunity to testify today in support of Senate Bill 659. I want to first just take a moment to thank you for all that you have done for citizens of Maryland, particularly over the last 2 years. We at Sheppard Pratt have been open each day, taking care of our most vulnerable, making sure access is available, and a lot of that is possible due to the active collaboration that we have with you all and with like-minded state agencies across. I want to specifically talk about this legislation and why it comes before you, because this legislature has made a priority of both equity as well as health equity. And when I think specifically about what we face right now, we have unprecedented demand. We have 13 of the largest outpatient clinics in the state. Each of them is seeing over a 40% increase in demand for services. When people are in crisis and they need access to care, most importantly, those that are most vulnerable, we've heard a number of bills this afternoon. The biggest piece that I will say is this is a simple bill in the sense that you have an agency and you have hospitals standing in front of you that want to take care of our most vulnerable. There are people that are waiting in emergency rooms today who need access to that care. And what this bill does is it simply says that barriers cannot be erected outside of medical necessity criteria that any person would have to prevent people from accessing that care. These barriers that we talk about are ones that people with commercial insurance or the means to pay privately do not face. It specifically affects people that are on public assistance. We should not have additional barriers for accessing medically necessary care. While Sheppard Pratt agrees that MDH should have the flexibility to set policies for the Medicaid program, those policies should seek to promote the best clinical care possible and avoid making arbitrary departmental policies solely based on budgetary constraints. We believe that this legislation reasonably balances those two goals, permitting MDH to create limits based on medical necessity while allowing clinicians to make decisions in the best interests of their patients. Thank you all for your time today. I respectfully request a favorable vote on this legislation.
Thank you. All right. We're going next to Jennifer Wilkinson, also of Sheppard Pratt.
Good afternoon, Madam Chair, Mr. Vice Chair, members of the Senate Finance Committee. Thank you for the opportunity to testify today in support of Senate Bill 659. Sheppard Pratt serves patients from across the entire state as well as nationally and internationally. The hospital offers psychiatric services that are not widely available other places throughout the state or even throughout the country. The Maryland Healthcare Commission has specifically cited the need for services for underserved populations, and in many cases, Shepherd Pratt is the only provider of these types of services in the state, providing key services as part of the overall behavioral health infrastructure. In the absence of these services provided by Shepherd Pratt, many of these individuals would seek care in emergency rooms or have negative health outcomes and not receive treatment at all. Because Shepherd Pratt is able to provide these unique services, it can support hospitals across the state by relieving the pressure on emergency departments and psychiatric units that often do not have the capacity or capability to manage these behavioral health patients. All of Shepherd Pratt's efforts, however, are contingent upon having the necessary funding to provide these types of services. This legislation under consideration removes these potential barriers to patients trying to access Shepherd Pratt's unique services. Removing these barriers ensures also that we are able to invest in providing and expanding our ability to serve special populations that would otherwise go untreated. Shepherd Pratt is committed to our mission of improving the quality of life of individuals and families. This legislation helps further that mission by ensuring that patients are able to access our care and services in the time of need. I would respectfully request a favorable report.
Thank you. Don't see any questions, so we'll go next to Dr. Todd Peters.
Madam Chair, Mr. Vice Chair, and members of the Senate Finance Committee, my name is Todd Peters. I'm a psychiatrist and also the Chief Medical Officer at Shepherd Pratt. Thank you very much for the opportunity to testify today in support of Senate Bill 659. We are truly grateful for your committee's leadership and support for behavioral health treatment in the state. We're also pleased that Shepherd Pratt, despite the very challenging times that we were in, was able to successfully open a new behavioral health treatment facility in Elk Ridge in June of 2021, with funding support from the Maryland General Assembly. Situated in the Baltimore-Washington corridor, the new hospital includes 85 inpatient beds, 4 specialized outpatient programs, a psychiatric urgent care setting, and a neuromodulation program, which really allows us to provide life-saving treatment to those most in need. The legislation before you largely seeks to address this administrative policy that we're all dealing with, unrelated to medical necessity, that MDH has had in place for several years. This policy requires emergency departments to receive at least 5 denials from several other hospitals that lacked psychiatric capacity before a Medicaid patient could be placed in a specialized psychiatric facility, such as Shepherd Pratt. For me personally, I always try to view policies through the eyes of patients and the clinicians that I also serve and care for them. So the current policy forces a Medicaid patient to be required to spend many additional hours sitting in an emergency department waiting for a bed to open or for the administrative hurdles to be cleared. This is after the clinical judgment of the clinicians have already concluded that an inpatient psychiatric bed is in the best interest of the patient. So this delay can result in individuals spending hours and days unnecessarily in emergency rooms, which are often very windowless and are really meant to be for short stays. So for the healthcare staff on the front lines, this policy means hours wasted calling around to different hospitals when a bed may be available in a specialty facility like our own. And this time that it takes to find placement, time that's taken away from direct patient care, even though the patient medically qualified for that service. So as a physician, I treat all of my patients to the best of my ability, regardless of race, gender, or socioeconomic status. It is troubling when I see policies that erect barriers to patients receiving the right care at the right time in the right setting. So I respectfully request a favorable report on Senate Bill 659. Thank you.
Thank you. Senator Augustine.
Thank you, Madam Chair. Thank you all for coming here and presenting this. And it's good because you guys are all from Shepherd Pratt. Maybe can you just tell me like how many folks from Southern Maryland or the Eastern Shore or Western Maryland or from Prince George's County for that matter could possibly be able to access this, these services?
Sure. So what I would say about Shepherd Pratt is that we have 182 unique programs across 19 counties across the state. When we talk about these programs, we receive patients from not only every single county and jurisdiction, but we are a receiving facility from every hospital emergency room across the state, which includes all of the areas that you just mentioned. And so we are truly, I will say, the safety net for the entire state. And the people that we take care of aren't able to access those services more locally. So they not only rely on our inpatient services, but then I will say we run the 13 largest outpatient community mental health centers across the state, as well as in terms of sheer numbers. In any given year, we take care of 70,000 individuals, 50,000 of whom are those who are most vulnerable across the state.
Okay, that's,
Let me butt in and ask one question, since we got this good professional panel here. You know, we often, well, I would say that very few of us would have time to read intensely every bill that we're going to hear. So we really are relying on those who testify orally to tell us more than what we see when we look at the title of the bill. And at the moment, what I know that Shepherd Pratt offers specialized care in this area, you're world-renowned, but what about the admissions restrictions? What are they now that this bill would address? And how is this bill creating equity?
Sure. So what happens right now is when someone is in crisis, they go to an emergency room, they will be evaluated by an emergency room doctor, and then that doctor will make a decision about whether someone needs to be admitted or not admitted. What is different and where the equity comes in is if you walked in and you had a commercial insurance, that emergency room would be able to pick up the phone and say, where is the bed available? Where does this patient need to go? What makes the most sense in terms of their treatment? However, if you were a recipient of Medicaid, there are different policies that come into being at different time periods. The one that Dr. Peters was talking about was one which specifically stipulated that if you are a Medicaid recipient, the emergency room doctor has decided you need admission. Just the fact that you're a Medicaid recipient means that that emergency room would have to call around, and until 5 acute care hospitals denied admission or said they didn't have the capacity, only then could they make a phone call to a Shepherd Pratt or a Brookline, which I believe is one of the other panels that are here, for access to a psychiatric hospital. So the issue here is if you are most vulnerable, you will sit in that emergency room for hours or days, whereas if you had commercial insurance or could afford to pay privately, you will get that bed faster, sooner, quicker. And the reality is this is particularly of concern when you think about how more difficult it is to access services in general, particularly if you're of low socioeconomic status, get over hurdles to even get to the emergency room. Finally, if you get to the emergency room, if you're going to wait 2, 3, 4, 7 days more than the person with commercial insurance, you're likely not going to come to the emergency room the next time you're in crisis. For this legislature, we talk a lot about equity and health equity. For this group, which is the IMD group that we talk about, life expectancy is still more than 20 years shorter. And so when you think about health disparities, this is one of the largest health disparities. And while there are many things that are super complicated, our own MDH should not get in the way of medical necessity for our most vulnerable being able to access services.
That's very helpful. Let me ask this. What would you say about the mechanism within this bill for fixing this problem?
So basically, the mechanism is that what it creates is the avenue to say things that are medically accepted standards that all insurance companies have to face, medical necessity, is the rule that even MDH needs to use. They cannot erect arbitrary barriers to access. And then the second part of that provision is beyond medical necessity. If they want to enact anything that will be restrictive, it has to go down the regulatory path. So it cannot simply be a departmental policy that just gets started on a whim or from nowhere, and then all of a sudden you have the entire hospital field trying to figure out how do we take care of this one group differently than every other that we're taking care of in the emergency room. So it is, I will say, simple and straightforward. I think the last piece that I would say is I think there was a letter provided by MDH. I believe they're in support, but there's a question about length of stay. We have looked at length of stay for IMD patients, this group that we're talking about. Length of stay that we have in the hospital is about 12 days. We take care of people who are acutely ill. We're not talking about long-term state hospital patients. We're talking about people who need to access crisis services when we are concerned for their own safety and the safety of others. And this is about making that care accessible so that people get the care that they need.
Thank you. Are there any other questions? All right, thank you very much. That's very
you.
helpful, I think.
Thank you.
All right. Dr. Todd Peters. Oh, you spoke already, okay. All right, then Jeffrey O'Neill and Michael Hand. You have 2 minutes each.
Thank you, Madam Chair, Mr. Vice Chair, and members of the Finance Committee. We thank you for this opportunity to also present in favor of the Psychiatric Hospital Admissions Equity Act, or Senate Bill 659. Brooklane Psychiatric Center, the organization that we represent, is also an IMD, as is Shepherd Pratt. And we'd like to thank our colleagues from Shepherd Pratt for inviting us to testify here as well. Brooklane serves we have a 57-bed facility and a full continuum of outpatient treatment services, and we serve the Panhandle in Western Maryland. The majority of our patients do come from Frederick County West, as well as Pennsylvania and West Virginia. This bill has created artificial barriers that prevent our local acute care hospitals from referring to our facility. They have prevented rapid access, and individuals often wait in the emergency room for extended periods of time, while our facilities at Brooklane could easily take care of those patients. This legislation permanently removes the limitations and barriers on institutions of mental diseases, or IMDs, such as Brooklane and Shepherd Pratt, and it opens up those resources to serve those vulnerable patients. We all value health equity, and at Brooklane, we're proud that over 50% of our patients are from our Medicaid recipients, and given that these are the individuals that are going to wait twice as long as other individuals to access those beds. Given this, Brooklane strongly supports a favorable report and asks your support in this endeavor as well. Thank you for your time and attention.
Thank you. All right, and Michael Hand.
Madam Chair, Mr. Vice Chair, distinguished members of the committee, I'd like to thank you for the opportunity to testify in support of Senate Bill 659. As the Chief Medical Officer for Brooklane Health Services, I advocate strongly in support of this legislation. As we all know and has been testified to previously, the United States and Maryland is in the midst of a mental health crisis, particularly amongst youth and our disadvantaged communities. And it is often our Medicaid beneficiaries that are the most vulnerable and most at risk for severe mental illness and in need of inpatient psychiatric treatment. The risk has only increased during the COVID-19 global pandemic, which contributed to historic delays in accessing inpatient psychiatric care and placed unprecedented strain on acute care emergency departments throughout our great state. We have also observed an increase in the already disturbing upward trends in mental illness amongst our youth. From 2009 to 2013, a 44% increase was reported in high school students having made a suicidal plan in the prior year. This disturbing trend, compounded with the disruptions from the global pandemic, led the U.S. Surgeon General, Dr. Murphy, to recently issue an advisory calling the challenges confronting American youth today unprecedented and uniquely hard to navigate. With these factors in mind, it is imperative to systematically eliminate the barriers to accessing mental health care in these vulnerable populations. Doing so will mitigate the impact of mental illness in our great state, promote health equity, and strengthen our healthcare system overall. And Brooklane stands strongly in support of this legislation. I'm happy to answer any questions.
Thank you very much. Okay, I see no questions. Thank you very much.
Thank you.
Very helpful. All right, we're going finally to Senate Bill 682, Senator Washington. If you want to come up to the podium or to the table, let me see who you have. You have a panel of Sam Williamson, Dr. Elise Pine, and Dr. Kellen Baker. As sponsor, take the time you need to explain the problem and how your bill softens or eliminates it. And all other witnesses, you have a lot of them, will have 2 minutes each. Okay.
Thank you, colleagues. It's wonderful to be here today to see you in person. For the record, I'm Senator Mary Washington, and I'm here to ask for your favorable report of SB 682. Chair Kelly, it's good to see you. Vice Chair, committee members. I want to draw your attention before I get started is that there's an amendment in your package, so it does change some of the drafting, but I will address that in my remarks. Again, thank you for hearing the testimony on SB 682. We see it as modernizing our Medicaid program to ensure that we are following best practices when it comes to gender-affirming care. I especially want to thank all of you who have co-sponsored this legislation. You know, when we're lucky, the right thing to do is really easy to accomplish. So this bill is easy. It requires only that we defer to medical expertise. Right now, our Medicaid program is failing in its coverage in gender-affirming care. Maryland continues to follow medical standards that were created almost 20 years ago, without regard to today's best practices or the significant advances in medical science that have occurred. Because Maryland is not keeping pace with medical field, our Medicare program categorically excludes dozens of gender-affirming procedures from coverage, regardless of the medical need or a doctor's prescription. SB 682 will bring Maryland in line with modern practices. We will be following the lead of over a dozen states, including Virginia and Washington, D.C., who already provide robust care for this vulnerable population. This bill was created through several meetings with the Maryland Department of Health, where we worked to share information on today's standards of care and to learn from the department how we can best provide sufficient medical care. As a result of those conversations, in collaborations with medical professionals from the Johns Hopkins Medicine, from MedStar Health, from Chase Brexton Healthcare, and other institutions, we feel very good about the bill before you. Our work with these providers has overwhelmingly confirmed how deeply necessary this medical care is. As you will hear, among the medical institutions that support this bill is MedChi. MedChi agrees that Medicaid must provide this care, and it identified a way to strengthen the bill, so you will see the amendment. It removes the specific procedures left in the current drafting, and it underscores the bill's ability to keep pace with medical science. So again, hopefully you have that amendment before you. Now, what the bill does is that it requires Maryland's Medicaid program to provide gender-affirming treatment in accordance with a newly created section 15-150. And that section has three main parts. First, it defines gender-affirming treatment as treatment that is, 1, medically necessary, 2, prescribed by a licensed healthcare provider, and 3, treats a condition related to the individual's gender identity. The definition also gives examples of what may be medically necessary for a particular individual. The amended bill that has been uploaded with my testimony keeps these examples general by referring to categories such as hormone therapy, voice therapy, and facial procedures, rather than the specific names of medical procedures. Secondly, the bill requires Medicaid to cover gender-affirming treatment when it is medically necessary. Medicaid must cover this care according to current non-discriminatory medical standards. The bill also prevents Medicaid from denying treatment based on an individual's gender identity, denying treatment because of debunked medical misinformation that necessary care is classified as cosmetic, or denying treatment without the benefit of an experienced medical provider's experience. The final section of the bill creates a report that would help connect Medicaid enrollees with appropriate providers. Now, always you have to be concerned with or have questions about a fiscal impact. This bill will have life-saving impacts on a small number of Marylanders. There are fewer than 2,000 transgendered Marylanders enrolled in Medicaid, and that is only 2% of the number of Medicaid enrollees with heart disease or stroke. And because individual needs vary, the number who will use these services is even smaller. For example, one study shows that only 13% of gender-diverse people need vocal surgery. The bill does not open the floodgates for these services. Because the number of individuals impacted by this bill is small, these costs are manageable and these costs are federally reimbursable. Looking at the illustrative examples in the fiscal note, one estimates on a faulty assumption that everyone is going to get all of the services, and that is just frankly not true. The more realistic estimate, as I said earlier, is quite small, and Maryland's share of cost for this more realistic number is 0.1% of the entire Medicaid budget. You all know I like numbers, so I had to put that in there. Moreover, by providing adequate medical care, our state will save on other costs. And either individuals will seek, if we don't do this, they'll seek unregulated, unsafe back alley care, which creates costly complications that end up in our emergency rooms, and then we end up having to spend even more. So rather than letting these costs escalate, it would make fiscal sense to just do this one-time cost. For too long, Maryland has been falling behind. Our Medicaid program is far out of alignment and with medical consensus and best practices. I want to remind you that over the last 2 years, we've extended Medicaid benefits we extended it to pregnant mothers for 2 months, and then we extended it for another year because the science says that you keep the mothers healthy, that the children will be healthy. We also extended dental care because we know of the correspondence between lack of dental care and other more costly healthcare costs. So again, in this population of transgendered individuals who are Maryland citizens and residents who work and play and are family members and who, except for their economic conditions, would not have access to the best adequate care and according to the best standards. So I ask you to have a favorable report on SB 682, and thank you so much for this opportunity to present it.
Thank you. I haven't had a chance to read through your bill, but I think it was smart that you have accepted or you have placed in the amendments to get rid of just very specific technical methodologies that might exist now. It might be superseded next year or the following year by something else.
Yes.
So I think that keeps the bill useful as the medical treatments increase and they remain fluid.
I'll accept the comment, the thanks, but I want to thank MedChi and people who are smarter about these things than I am.
Okay.
Like, for example, my panel that I'd like to present.
Okay, and panelists, you have 2 minutes each. We'll start with Sam Williamson.
Thank you, Chair Kelly, Vice Chair Feldman, and members of the committee. My name is Sam Williamson. My pronouns are they, them, and I'm a lawyer with the Homeless Persons Representation Project. We have offices in Prince George's and Montgomery County and Baltimore City. My organization strongly supports SB 682 for 2 big reasons. 1, this bill brings Maryland into compliance with the best practices medically and with legal standards. And 2, it will have a profound impact with a minimal impact. It'll have a profound impact on people's lives with a minimal impact on our budget. In 2016, the Maryland Department of Health created a policy on gender-affirming care. It was based on standards that are outdated, and it created 31 categorical exclusions for gender-affirming care, meaning that there are 31 procedures people cannot access no matter what. These exclusions are out of compliance with federal and state laws, and several courts have found these categorical exclusions to be illegal. They're also out of compliance with non-discrimination provisions. SB 682 brings Maryland into compliance with medical and legal standards. It follows the paths of other states that have already codified requirements that gender-affirming care coverage must be tied to current clinical standards and that coverage must be individualized, meaning no categorical exclusions like the ones seen in Maryland today. Many other states have also recognized that this treatment is cost-effective. In Maryland, that is also true. Our state Medicaid budget is $14.1 billion, and we have a $100 million surplus. The cost of this care is a small drop in a large bucket, and that is especially true because of the federal reimbursement. We will also see cost savings because when we provide adequate gender-affirming care, the physical appearance of transgender people is more able to be in congruence with the internal sense of self. That acts as a protective barrier against discrimination when seeking stable housing and stable employment. SB 682 makes fiscal, medical, and legal sense, and I strongly urge you to issue a favorable report. Thank you.
Thank you. All right, I don't see any questions. All right, we'll go next to Dr. Elise Pine.
Good afternoon, Senator Washington, Chair Kelly, Vice Chair Feldman, and members of the committee. My name is Elise Pine, and I'm a pediatric endocrinologist at Chase Brexton Healthcare, an FQHC that provides medical and mental health services for over 5,600 transgender and non-binary people. I am here to support SB 682. I have been providing gender-affirming medical care since 2011, and my practice is based on the standards of care set forth by the World Professional Association for Transgender Health, or WPATH. The WPATH standards set forth the foundational tools for identifying and treating gender dysphoria. The standards are respected by leading physicians both in the United States and internationally. And all major medical organizations agree that this care is medically necessary. The current Maryland policy has a long list of exclusions. One set of exclusions is for facial procedures. Facial features such as jawline and Adam's apple are associated with specific gender. An appearance that does not align with a person's outward gender expression causes internal distress and poses specific safety concerns. By 3 months of age, infants can perceptually distinguish faces based on differences in gender. A 2020 study found that following facial feminization surgery, all patients had improved quality of life, more feminine gender appearance, and high satisfaction. One of my patients, a bright college student, had difficulty attending her classes due to daily significant facial hair growth that would return each afternoon. She requested electrolysis, but it was an excluded benefit. And this affected her academically and socially as she could not leave her room for more than a few hours at a time. Some of my patients have had such terrible discomfort with their speaking voice that they developed selective mutism and would not speak. Following voice therapy, our visits changed from silent to chatty, with confidence in finding their authentic voices. WPATH's position is that medical necessity must be determined on an individualized basis with the patient's medical providers. The treatments I discussed today are neither cosmetic nor experimental. They are well-researched, highly regarded, and life-saving. The low-income Maryland transgender community deserves this life-saving care. I urge you to vote in favor of SB 682 with Senator Washington's amendment. Thank you for the opportunity to speak here today.
Thank you. I don't see any questions, so we'll go next to Dr. Kellen Baker.
Good afternoon, Chair Kelly and distinguished members of the committee. Thank you for the opportunity to testify in support of Senate Bill 682. My name is Kellen Baker, and I am the Executive Director of Whitman Walker Institute. Whitman Walker is a federally qualified community health center that serves 20,000 patients annually from the DC and Maryland area. I hold a PhD in health services research from the Johns Hopkins School of Public Health, and my research focuses on the transgender population, particularly the legal and economic aspects of coverage for gender-affirming care. Maryland Medicaid has previously been a nationwide leader in working to ensure that transgender people can access the health care they need. As the field of trans medicine has advanced, further clarification is now needed regarding the appropriate scope of coverage. In Washington State, legislators updated the Medicaid program in 2021 to clarify coverage for puberty delay medications and a broad and non-exhaustive range of gender-affirming surgeries. Like Senate Bill 682, the legislation also directed the Insurance Commissioner and the Medicaid agency to issue a regular report on access to gender-affirming services across the state. Colorado recently took a similar step through its Essential Health Benefits Program. With approval from the federal government, plans now must cover procedures that include, for instance, facial surgeries and electrolysis. An analysis commissioned by the state to assess the cost of this coverage estimated it to be 0.04% of allowed claims. My own recent research indicates that each transgender person in a national insurance claims database incurred an average of less than $1,800 in costs per year for gender-affirming surgeries and other care. Considered on a per-member per month basis, the budget impact of that coverage is 6 cents. Maryland's commitment to the health and well-being of its Medicaid population is critical. Gender-affirming care is not expensive when considered from a payer or societal perspective, but it is often beyond the reach of trans people who rely on Medicaid. Communal assistance to individuals in need reflects the core purpose of the Medicaid program, and clarifying that Medicaid supports transgender Marylanders in seeking essential healthcare services is both a moral and economic imperative. I strongly urge you to support Senate Bill 682. Thank you.
Thank you. One thing just occurred to me as I've been sitting here listening is, are there minimum age requirements for a person receiving some or all of the gender-affirming treatments that you have now?
For surgical care of any type, members have to be 18 years of age to consent for themselves to get any kind of surgery.
Now, if a family were dealing with a much younger person, or let's say a low teen, who felt the need for medical treatment and desired it, and if the parents were in agreement with the state of the law in Maryland. And
So parents can consent for their children to receive medical care, and especially for puberty blockers, which is a reversible type of medication that just delays puberty without any permanent changes, that can give children time to get older, make sure they're ready for any kinds of other types of changes.
Okay, that's helpful to know. Senator Reedy.
Thank you. I had the question about puberty blockers, so it is reversible.
Right, so if somebody took puberty blockers and then stopped, they would continue on the same path that they had been on.
Is there a point of no return with puberty blockers? I know you're saying it's already covered, I'm just curious.
Well, no, if you stopped taking it, you would continue where you were, but eventually
Delayed,
people have to be
obviously.
in some type of puberty. You can't take puberty blockers forever.
Right.
So either people at some point go through their own natural puberty or start to take hormone therapy to affirm their gender.
As you were giving your testimony, I mean, listen to all the testimony, I'm sort of struck by, I'm reading through some of the things that this bill is seeking to get covered. And a lot of it, you're saying it's not cosmetic. We would call it, colloquially, I would call it cosmetic surgery just because that's what you'd think of it as. You're saying it's not really cosmetic, that it's critical to the person's ability to be their most authentic self. Some of this, though, sounds like conforming to a gender stereotype. I mean, society's basically moving in the direction, isn't it, that really there isn't a lot of difference between men and women as far as the gender, correct? I mean, you would argue that me calling, just because you may present as a woman, I shouldn't assume you're a woman. So why are, we're going to start having Medicaid pay for procedures simply because that person will feel more like a woman because they don't have facial hair growing? But why are we doing that if that's not really what defines a woman?
Gender dysphoria is the internal distress a person feels when their own gender identity does not match their physical body, regardless of appearance to other people, their own physical appearance and their own physical self.
So they feel that they're, in this
Right.
case.
There's two parts. One is how your own body feels. The other is how other people see you.
How do we draw the line when we're talking about taxpayers funding these procedures, which is what we're talking about? How do we draw the line between someone's strong feelings that may have been diagnosed by a mental health professional or by a doctor like yourself that specializes in this? Where do we draw the line to say we're going to allow you to, we're going to have a taxpayer funded surgery for something that is really based more on a very strong feeling?
If I might, I think that's precisely that the stipulation is that it's medically recommended. You can't just, without your doctor, without a diagnosis, you can't just walk in And while you may in your social life and everywhere present a gender that you were not born in, this being eligible for the state to cover anything related to that has to be under the guidance and with the prescription and with the medical doctor. So that's the line. Whereas our discrimination laws don't draw that line. Our discrimination laws
I
don't
can't
require.
discriminate you just
Right.
because.
We don't require the surgery, we don't, we don't require these things. So that's not a line we draw in our civil code.
So then-
However, in this, you were precisely right, that there is a line, just like with any benefit, we draw a line. And so the line is that it has to be part of a medically necessary.
That's good. That's good. So where, as a doctor for you, where would you draw that line when someone comes to you between very strong feelings? Because someone could have very strong feelings that make them feel like they don't want to, that they're very upset about any number of things in their life. Where do you draw that line? How do you make that diagnosis? That it's actually medically necessary as opposed to just salving a feeling?
So medical necessity is defined that cosmetic surgery is surgery performed to reshape normal structures to just improve self-esteem. Okay, whereas medical necessity is when there is trauma, infection, disease, or some type of condition, medical condition that you're treating, and gender dysphoria is recognized as a medical condition. So just, for instance, as this is not a perfect example, but bariatric surgery to lose weight is performed on certain.
Right.
Right.
Sure.
So, and you might say, okay, well, not depending on how you feel, there are certain qualifications.
I would just, thank you. I would just add that the medical community is very clear in its consensus that these procedures are medically necessary. Every major organization that's put out a statement has said these procedures are medically necessary for this population. So it's apples and oranges to talk about these procedures for a cisgender population versus a transgender population.
It's great. And so my question would be, then, they're medically necessary in what cases?
Yeah, absolutely. When they meet the criteria that are put forth by the World Professional Association for Transgender Health. And so it's medically necessary when somebody is diagnosed with gender dysphoria. It's a specific diagnosis that's separate from being transgender. It's its own diagnosis and is treated, and everybody is very individual. And so this bill, what is really excellent about this bill is that it allows individualized coverage. And so to your question about gender stereotypes, the bill does a great job of showing that people are individualized in the care that they need. And so we are just deferring to the medical community because we know that we are not the experts. The medical community here is the expert. And you'll hear many doctors who are going to testify today.
Thank you for the answers. Thank you, Madam Chair.
Thank you for the questions.
Actually, I hadn't planned to say this, but there was a young man in my district who called me when he heard about this bill and asked, would it be here? He's actually a late teen, I think. And he said, I was born with one testicle, and there are some other physical characteristics of my body that I can see. He says, I don't know what my endocrine system is like, but I think that I might not be what's on my birth certificate in terms of how I feel and other things that to me are apparent as not typically related to one gender or to the other. I would imagine that there are endocrine system things, there are physical things, there are psychological things that when you are not the person in that particular body or in that particular psyche, maybe it's hard for you to understand, but I don't think we ought to put down another person's experience of their reality.
Thank you for that. And this has been a very humbling and as honored, as an out African-American woman who is cisgender, to be able to move this bill forward, because it's not an experience that I have, but I definitely can connect to discrimination or the lack of access to care based on who I am. And who I am, who I love, and all sorts of perceptions. So I think it's a responsibility, as you highlight, for us to not judge an individual's experience, but to support and remove barriers, particularly in the case of something like Medicaid, particularly in the case in benefits that are provided to everyone based on basic criteria, to not exclude their ability to take advantage of these based on who they are.
Okay. All right, let's go next to the following persons: Paula Niera, Ann Geddes, Margot Quinlan. If we have enough room, we can take C.P. Hoffman also. And you may go in any order to state your name. Everybody has 2 minutes each. And those mics are movable.
Thank you, Madam Chair, Mr. Vice Chair, members of the community. Thank you for the opportunity to testify on behalf of Johns Hopkins University and Johns Hopkins Medicine in favor of Senate Bill 682. My name is Paula M. Nera. I'm a nurse and a lawyer. I currently serve as the Program Director of LGBTQ plus Equity and Education at Johns Hopkins Medicine and our Office of Diversity, Inclusion, and Health Equity. And I served as the founding Clinical Program Director of our Center for Transgender Health. In the 5 years of the existence of our center, we've provided care to hundreds of transgender and gender diverse Marylanders, including some of the most vulnerable fellow citizens who have to rely on Medicaid to be able to access gender-affirming care. However, one of the most frustrating things that our patients and our clinicians encounter that's heartbreaking when we know we have the ability and the expertise to provide care to help them, and we can't. We know how important these life-altering and in some cases life-saving treatments are for our patients, but we can't move forward because of the existing limitations in Medicaid coverage, or that we receive negative benefit determinations when those decisions are made by individuals who have no expertise or experience in transgender and gender-affirming care. Only clinicians with experience in this area should be making those decisions on medical necessity and for coverage. Treatments such as facial gender surgery, hair removal, vocal surgery, or speech pathology can improve a person's sense of well-being and confidence in living as their authentic self, which may be the difference in being able to reduce the negative impacts of social determinants of health, such as employment or housing discrimination, or the risk of being the victim of transphobic violence. And today, we as clinicians have to say, sorry, Medicaid won't cover this, and we're unable to move forward. At Johns Hopkins, our focus is moving medicine and healthcare forward for everyone, for all of us. And this bill will help our community and our practitioners be able to provide the care that some of our most vulnerable fellow citizens absolutely need. Thank you.
Thank you. All right, I don't see any questions, so we'll go to Ann Geddes.
Hi, thank you, Madam Chair and committee members. My name is Ann Geddes, and I'm here testifying now as the mother of a transgender child in support of Senate Bill 682. Our son Jordan, who was born a girl, developed significant mental health problems as an adolescent, including severe self-injurious behaviors and multiple suicide attempts. These problems developed at the same time that he decided for himself that he was not of the gender assigned to him at birth. From the age of 2, he tried to pass himself off as a boy from time to time, but when he became an early adolescent, he decided that that gender was wrong for him. He was a boy. Because of his significant mental issues at the time, his father and I very mistakenly did not permit him to undertake any gender reassignment measures as an adolescent. Because of his untreated gender dysphoria, Jordan ended up costing the state a tremendous amount of money. At a significant cost to the state, he spent 5 months in a Maryland residential treatment center, which was paid for by Medicaid. He experienced multiple inpatient hospitalizations, which were paid for by Medicaid. He lived for 1 year in a residential rehabilitation program, RRP, which was paid for by Medicaid. At the age of 19, when Jordan began his gender-affirming treatment, his mental health challenges dramatically improved. He stopped self-injuring, there were no more suicide attempts, and he got sober. He had developed alcoholism. He moved into his own apartment. He finished college. He got off of SSI. He'd been on SSI since the age of 18. Then he got off of SSDI, and he's now employed as a software engineer with a well-paying job. Jordan is now a Maryland taxpayer. He is a giver, not a taker, at great savings to the state. Our son's gender reassignment surgery was truly transformative. All transgender individuals should have the opportunity to live a happy and productive life. Senate Bill 682 would support this end. Please, I ask you, return a favorable report. Thank you.
Thank you. All right. We'll go next to Margot Quinlan.
Great. Thank you, Chair, Vice Chair, members of the committee. My name is Margot Quinlan. I am with the Mental Health Association of Maryland. We are here in strong support of this bill. I want to speak today on the unique intersection of mental health and trans health care. Minority stress describes the chronically high levels of stress faced by members of stigmatized minority groups. It may be caused by a number of factors, including interpersonal prejudice and discrimination. And numerous studies show that transgender individuals are at particular risk of psychological distress from elevated exposure to harassment, discrimination, and societal oppressions. This minority stress may make trans and non-binary people more vulnerable to the development of behavioral health concerns such as anxiety, depression, or substance abuse. Alternatively, access to gender-affirming care has been shown to increase mental well-being and is associated with a decrease in mental health treatment over time, as you just heard. It can lead to increased congruence with gender validation and overall reduction in the minority stress caused by discrimination and harassment. Without adequate medical care, transgender Marylanders are exposed to job and housing discrimination, harassment, and interpersonal violence. The state ultimately pays for the rising costs of this discrimination through emergency room visits, hospitalizations, and over-reliance on our mental health care system, and Maryland is falling behind much of the nation as a result. The Mental Health Association expects this to be a relatively inexpensive change to the state Medicaid plan, yet one that would have tremendous impact in improving the health and mental well-being of our transgender communities. This care is life-saving, it is medically necessary, and it must be made accessible to all who need it. For these reasons, the Mental Health Association urges a favorable report on this bill. Thank you.
Okay. See any questions? We'll go next to C.P. Hoffman.
Thank you, Chair, Vice Chair, members of the committee. My name is C.P. Hoffman. I am the Policy Director at Free State Justice, which is Maryland's statewide LGBTQ advocacy organization. Among other things, Free State Justice runs a legal services program for low-income Marylanders on legal matters arising out of their sexual orientation or gender identity. So we represent a lot of trans Marylanders on healthcare-related matters. One of my clients is actually in the room here today, and she's going to be testifying in a few minutes, Erica Burns. I'm going to let her tell you her story rather than me. But I do want to talk to you a little bit about, what happened after she came to us. Because, she came to us and said, the Medicaid system is not paying for these surgeries for me because they just have a per se bar on them. And so we appealed her case, and we went before an administrative law judge a few months ago. And that hearing was really frustrating in a lot of ways because the opposing counsel for the managed care organization basically had a witness that said, well, did you do an individualized assessment of this, of Ms. Burns? And they're like, yes, we looked at this and it was, the care was on the list of things that were prohibited. So we did an individual assessment that it was prohibited. And so we were like, but did you do an assessment of whether she actually needed this care? And they're like, not really, we just looked and saw that it was prohibited. So I we presented our case, and I argued to the administrative law judge that this was unfair and discriminatory. And in the end, we got a decision that ruled on behalf of the MCO and had a footnote that said, counsel for the appellee or for the appellant, made a strong case about discrimination, but I don't have jurisdiction to rule on that. So they should try to go somewhere else to see if some other forum will address this. So I'm here today to ask this committee to please pass a favorable report on HB 692 so that Ms. Burns and others like her will be able to get that individualized assessment that she's been promised. Thank you.
Thank you. All right. I think we heard from everybody on this panel. Okay, well, very enlightening. We're going next to Sergio Lizama, Joanna Diamond, Helene Hedion, and Kaylee Schmutz. I might be messing up somebody's name, but forgive me. Okay. You have 2 minutes each.
Chair Kelly and members of the committee, thank you for the opportunity to testify in support of the bill, of the Senate Bill 682. My name is Sergio Lizama, and I'm an adult endocrinologist, and I currently work at MedStar Health. I've also been living in the state of Maryland for the past 7 years, and I consider myself an advocate for the transgender community. The transgender community, for those who don't know, face the daily discrimination or refusal of care from their providers, are uninsured at a higher rate than their cisgender counterparts, and if are insured, they experience denials of coverage from insurance companies, not to mention the disproportionate rates of violence on the basis of their gender identity. While Medicaid has been covering these services in the state of Maryland since 2015, the coverage is limited and outdated, often not following evidence-based practices or updated standards of care. There are around 22,000 Marylanders who identify as trans who live in the state of Maryland, and only about 1% are currently enrolled in Medicaid. Some of these adults are my patients, and I know they struggle accessing some of these proposed services, causing them distress, depression, and sometimes also attempting against their lives. This 1% of beneficiaries deserves these proposed services. My patients deserve these services to achieve goals of continuity of care and positive health outcomes across the life course. Madam Chair and members, thank you for the time and consideration. I urge you to support SB 682 and give our transgender Maryland community the opportunity to access the same type of health care anyone else in this room has access to. Thank you.
Thank you. All right, I don't see any questions, so we'll go next to Joanna Diamond.
Good afternoon, Chair Kelly and members of the committee. My name is Joanna Diamond, and I'm the Director of Public Policy for Healthcare for the Homeless, and we stand in strong support of SB 682. At Healthcare for the Homeless, we see firsthand the denial of gender-affirming care and how it negatively impacts our transgender clients. And for our providers who are stymied from connecting their clients with the most up-to-date and comprehensive gender-affirming care available because Medicaid won't cover it, it is both frustrating and heartbreaking. You have our testimony with stories from our providers and clients about the impact of both being denied and provided gender-affirming care. And you've of course, heard testimony before us about the many impacts on a person's physical and mental health on being denied this critical care. You also heard from Senator Washington and some other panelists before me about the types of costs that are associated with transgender populations being denied this medically necessary gender-affirming care, and also references to the cost savings. And I'm just going to focus my testimony on transgender individuals who are experiencing homelessness, which is something that our organization specifically works with. So I'll start with housing. The connection between housing and a person's health are absolutely evident. Homelessness historically creates new health problems and exacerbates new ones. For transgender individuals, this is sadly also the case. A lack of comprehensive medical care makes them more likely to be targeted as trans, resulting in discrimination in employment and housing in other areas. As a result of this pervasive discrimination, a person's likelihood of experiencing homelessness significantly increases. It's estimated that 20% of transgender individuals do not have secure housing. And in a Baltimore study, more than half of those surveyed reported lifetime homelessness or housing insecurity. The complicating factor of homelessness exacerbates other existing inequities, particularly in mental and behavioral health care. Suicide and substance use rates among transgender individuals experiencing homelessness were almost double those of their housed counterparts, thus, of course, leading to costly emergency visits and hospitalizations. Medicaid routinely pays for this type of medical care. In addition to poor health outcomes and housing outcomes for transgender individuals, we've also, of course, heard about other areas of poverty and violence this population experiences. The effect is that they must rely on remedial measures in order to survive, rather than preventative services that could have avoided the dire consequences and costs altogether. Marylanders pay for these rising costs of discrimination through ER visits, hospitalization, homelessness, mental health care, joblessness, and social programs and social safety net programs. This affects us all and not just the trans community. The reality is that gender-affirming care is basic and essential health care for transgender Marylanders. It is both irresponsible and unconscionable for Medicaid to deny coverage of these medically necessary services. Thank you, and we urge a favorable report.
Thank you. Did you say you were health care for the homeless?
Yes. Chair.
Kevin Lindemood is a good friend, and tell him I said hello. I know he's executive director. That's one of my charities.
Oh, thank you so much. I absolutely will. He will appreciate that.
All right. Okay. Helen.
Good afternoon.
Helene Hedian.
Yes. Thank you for allowing me to speak in favor of this Senate Bill 682. My name is Dr. Hedian. I'm an internal medicine physician who practices primary care in the Baltimore area. I completed my medical school and training in Maryland, and I've been in practice for several years at Johns Hopkins Medicine. A large portion of my patient panel is transgender or non-binary, and I provide gender-affirming care, including hormone prescribing. I have met and cared for hundreds of transgender people. I teach doctors in training about the medical needs of transgender people. I have lectured on this subject at local hospitals and national conferences. The current coverage for transgender care is important, but it leaves several critical gaps. In a body which has been through masculine puberty, there are many changes, particularly to bone structure, facial and body hair, and voice pitch, which are not significantly altered by taking hormones. Facial surgery and vocal surgery and speech therapy are medically necessary procedures. Body contouring is a medically necessary procedure. Hormones do not always lead to sufficient changes to muscle bulk and fat distribution, and there may be medical reasons which limit someone's ability to take hormones permanently. These procedures are not cosmetic. They are not elective. They are the difference between being able to walk down the street unobserved and being challenged, confronted, or even assaulted. The lack of tolerance and compassion that leads some people to harm those that they don't identify with speaks to a larger problem with our society's limited understanding of gender. And there should absolutely be space in our society for gender nonconformity and a celebration of the spectrum of gender. But the sad truth is that when people are not immediately identifiable as transgender by their appearance or the sound of their voice by a malicious stranger on the street, they are safer. For many people who don't have the financial support of a family network, saving money for procedures like this simply is not realistic. And this is ultimately the point. Each of the procedures set forth in this bill is medically necessary. Some of these procedures are relatively inexpensive for a health plan, but cost prohibitive for an individual. Other procedures are more expensive, but will not be used by as many people. I have seen firsthand improved physical and mental health, which comes from living in a body which is finally aligned with someone's gender identity. I have seen a patient take ownership of their health, make healthier choices to better control their diabetes and heart disease, ultimately a cost savings. I have seen someone who was chronically suicidal start graduate school and begin to envision their own future. Each person is unique. Not every person will need or utilize every service, and compared to the total population of Maryland, the number of transgender people is relatively small. Yet passing this bill will make a dramatic improvement on the lives of people who need and deserve this care without expending a disproportionate amount of resources to accomplish this goal. I urge you to issue a favorable report for SB 682, and thank you for your time.
Thank you. Earlier, I think there was a colloquy going back and forth between me and an earlier panelist as to whether it made sense not to put into the law the list of procedures because they might change, they might be added to, something might become outdated as a way to get a certain outcome, and so on. Where are you on that?
I agree with the amendment as it is written by Senator Washington.
Okay.
I simply hoped to, from my medical context and experience, provide examples to give context for the panel on the current state of gender-affirming care and the benefits of that care.
Thank you.
Yeah.
Okay, let's see, are we down to Kelly Schmitz?
Yes, thank you, Madam Chair, members of the committee. My name is Callie Shumitz. I'm with the Maryland Center on Economic Policy. We are a nonprofit, nonpartisan research organization, and we believe that all Marylanders should be able to achieve their full potential in a healthy economy that offers a widely shared and rising standard of living. Ensuring access to comprehensive health care is a critical part of advancing that goal, which is why we're here in support of Senate Bill 682. I don't want to be too redundant, but I do want to underline our agreement with the testimony of prior speakers. Everyone deserves health care that meets their individual needs. And people who use Medicaid to fund their health care deserve to have standards that keep up with best practices. Investing in the health and well-being of transgender Marylanders through SB 682, like other expansions of Medicaid, has wide-ranging benefits. It increases the economic security of the people who are receiving Medicaid benefits. People who are able to access gender-affirming care are going to be able to be more successful in other areas of their life. They have all of their health needs met. And we know that the money invested, that the state invests in Medicaid, will then be spent in our local communities. It's just the nature of the program. So that has broader benefits as well. And finally, the gender-affirming care outlined in SB 682, as others have mentioned, is federally reimbursable. So it allows the state to leverage federal funds with minimal state investment. Because of the discrimination in employment, housing, and other public settings that transgender Marylanders experience, that this population experiences much higher rates of unemployment, poverty, economic instability than the Maryland population as a whole. Ensuring that transgender Marylanders enrolled in Medicaid can access gender-affirming care would be one significant step towards addressing these broader challenges. So we would ask for a favorable report. Thank you.
Thank you. All right. We're going next to Erica Burns, Claudia Teixeira, Emily Scott, and Calvin Schuster. Okay, you have 2 minutes each, and you may go, and the mics are movable.
Thank you, Chair Kelly, Vice Chair Feldman, and members of the committee. I'm grateful to be here today. And my name is Erica Burns, and I would like to talk to you about limited access to gender-affirming care under Maryland Medicaid. Now, I just want to start off by saying I am grateful to Maryland Medicaid for having covered surgeries such as breast augmentation and gender reassignment surgery. I am very thankful for that. However, unfortunately, that does not encompass an entire transition from male to female in terms of what for me personally is necessary for my own dysphoria easing. There's also the aspect of, for me personally, facial feminization surgery, which eases the dysphoria that came from a male puberty I was forced to go through because I did not have access to blockers or hormones at the time, back in the early 2000s, and I did not have professionals, parents, teachers, anybody who was there to actually protect me as opposed to the opposite.
I am advocating for coverage of this, as well as electrolysis, which comes from permanent hair removal, both of the face and the genital region for surgical preparation, two things which Maryland does not cover. And several years ago, when I realized Maryland would not cover this, I took to abusing alcohol to cope with it, and I would pluck my facial hair one by one in the mirror. I would even go as far as waxing the facial hair off of my face, which would rip skin off of my face, leading to a gruesome sight. After that, I was fortunate enough to run away to LA, where I was able to get electrolysis covered under insurance there, state and Medi-Cal insurance there, and it did help alleviate my dysphoria of not having to feel stubble in my face, not having to shave every day, not having manliness that is a very gendered thing, whether there's, less constructs supporting the binary these days or not. So with that said, I did have to move back here upon COVID-19's great reset, and I have therefore since been expected to face my trauma, which I am doing today, in fact. I am facing my trauma, and I am advocating for coverage of these procedures for those who have not been as fortunate as me to obtain electrolysis in other states, and for facial gender affirmation surgery for everyone. There are states such as Massachusetts, Connecticut, New Jersey, Minnesota, New York, of course, California. Let's name a few others. Washington, D.C., I'm probably forgetting a few. Oh, right, Colorado. It's time Maryland, as a so-called blue state, steps up its game, and I urge you to please vote in favor of Senate Bill 0682. Thank you.
Okay. All right, thank you. Okay, Claudia Teixeira.
Dear Chair Kelly, Vice Chair Feldman, and members of the Senate Finance Committee, thank you for the opportunity to testify in support of Senate Bill 682. My name is Claudia Teixeira, and I'm a medical student at the Johns Hopkins University School of Medicine. I'm speaking today in support of Senate Bill 682, which would bring Maryland Medicaid Assistance Program up to date with the current guidelines from leading healthcare institutions, including the American Medical Association and the American College of Physicians. The law as it stands now denies medically necessary care to a systemically marginalized community, and doing so, it actively perpetuates harm to this community. The guidelines from the American College of Physicians recommends that public and private health benefit plans include comprehensive transgender healthcare services. This is founded in a wealth of research that demonstrates how systemic inequity in healthcare for the transgender community manifests in disparities in health, including mental health, disability, heart disease, and cancer, to name only a few. These adverse health outcomes are the direct result of lack of healthcare access, and they're yet more severe for transgender people who occupy other systemically marginalized identities, including those who are disabled, people of color, of low income, and middle-aged. The data is clear that improving access to gender-affirming procedures results in improved health outcomes, and there is broad consensus within the medical community that this care is medically necessary. Barring procedures from coverage interferes with the ability of physicians and other healthcare providers to care for their patients. The law should support the provision of medically necessary care, not obstruct it. I have also seen how being able to access gender-affirming care has impacted my friends, loved ones, and myself. Being able to present to the world in a way that reflects one's identity has an immeasurable impact on overall well-being. As someone who will rely on gender-affirming care to be able to live authentically in my own gender identity, the thought that I could be denied care based on insufficient coverage is deeply upsetting. Knowing that care is available to me has had a profound impact on my own life. Please support Senate Bill 682 to bring Maryland up to date with the current standards in medicine and public health. Thank you for your consideration.
Thank you. All right, we'll go to Emily Scott.
Good afternoon, Madam Chair, Mr. Vice Chair, and members of the Finance Committee. Thank you for the opportunity to speak in favor of this bill. I serve as pastor of St. Mark's Lutheran Church and Dreams and Visions, two congregations in Baltimore that affirm and welcome transgender people. I am immersed in the transgender community as someone who is myself transgender and who ministers to transgender people. As a pastor and as a Christian, I believe that God created a beautiful diversity of human beings, and some of God's children are transgender. Transgender people are a part of God's plan. We are people with unique gifts and perspectives who have much to offer our society. But we can only do so when our identity is affirmed, allowing us to be healthy and well, as has been documented by so many of the experts who have spoken today. In my ministry, I have seen firsthand the pain and suffering of congregants who do not receive affirming care, especially because they are low income. One of my congregants, a formerly homeless trans woman, struggles greatly with dysphoria, and I'd like to note that dysphoria is not just a bad feeling. Dysphoria is much more than that. It's a central conflict of identity where it feels that who you are is not matching the way that your physical appearance is. And my spouse has struggled with it greatly, which led to addiction for many years of his life. It's a medical issue and should be treated as such. For this congregant, her dysphoria has resulted in extreme depression as well as neglecting her physical health. As a result, she frequently visits the emergency room. With trans-affirming care, these visits could be avoided. Speaking from my perspective as a Christian and a pastor, trans-affirming care will ease the suffering of God's children. Throughout the Bible, God commands us to care for the poor, the widow, and the orphan. God demands our care for transgender people who qualify for Medicaid because they are among the most vulnerable people in our society. They deserve the very best medical care that will allow them to be healthy and well and live their lives to the fullest. Thank you for the opportunity to speak.
Thank you. All right, and then finally, we'll hear from Calvin Schuster.
Thank you, Chair Kelly, Vice Chair, and members of the Senate Finance Committee. Thank you for the opportunity to testify in support of Senate Bill 682. My name is Calvin Schuster, and I'm a medical student at Johns Hopkins University School of Medicine. One of the first lessons I learned during my medical education is the importance of equitable access to care. As you've already heard, Senate Bill 682 addresses a critical issue of health inequity. The conversations that I've had at Hopkins and beyond have also shown me the overwhelming support of current healthcare professionals for this bill. Along with being a medical student, I'm also a transgender man, and I've experienced firsthand the importance of gender-affirming care in my own life. Being able to access care has improved my quality of life drastically, enabling me to live authentically as myself, to focus on my education, and to become an active and thriving member of my community. If I were unable to access the care that I needed, I'm confident that I would not have made it to where I am today. Finally, I'm the Director of Wellness at Trans Maryland, a community building and advocacy organization that runs the state's largest peer-to-peer connection space for Trans Marylanders. Through this work, we have talked to thousands of transgender Marylanders about the barriers to care that they face. The Trans Health Equity Act of 2022 emerged from those conversations, which highlighted to us that Maryland's current policy is based on standards of care that are over 20 years out of date. Lack of access to this care can be dangerous, impacting housing, employment, and education, as you've heard. Supporting this bill will help bring Maryland in line with current scientifically supported and evidence-based standards of care. Please consider supporting Senate Bill 682 to help create a happier, healthier, and more equitable Maryland. Thank you for consideration.
Okay, I don't see any lights on, so thank you very much for your testimony. And I think that ends the testimony on this bill, and we appreciate everybody who has done so. Okay. Senator Bidle.
Thank you, Madam Chair. Today, on the floor, I held Bill 263 for us to reconsider an amendment. And Mr. Smolsky has the amendment ready. Can we take a minute to look at it? Thank you. I'll explain it while he's passing out. So it's Bill 263.
Would you prefer to do it when we've got a full committee, or what do you think?
Well,
No. Okay. all
I'm
right.
going to.
For your, okay.